Yeah. 2025, I get to wear glasses now. So I am here. Enrique is here. Cheryl is here. Michelle.
I'm here.
Good, thank you. Sally here. Yep. And Dr. Laura's here. Bonnie's here. And Tony's going to be late. Susan Miller is an excused absence. Misty?
I'm here, Bill.
And Robert's here. So we have plenty. So 9 out of 11. Fabulous. So we will begin with our usual review of the March meeting synopsis minutes that were in your board packet. Any questions? Oh, here it comes. Any questions on the meeting summary synopsis? If not, I'll take a motion to accept the meeting synopsis as presented.
This is Robert. I make that motion.
Okay. Motion by Robert, second by Bonnie. All in favor, say aye.
Aye.
Anybody opposed? Hearing silence, we'll go with that passes. All right, this is our big annual rate renewal meeting. Right?
I'm signing ahead of time.
We all live for April, right? This is what we all enjoy, why we signed up. It's gonna be a hell of a meeting. Okay? So let's get started with our round 3 renewal overview from Mercer. Kirsten, kick this off.
Thanks, Bill. Good afternoon, everyone. It's good to see you. For those of you who are here in person, it's always really good to see you, and also looking forward to joining us virtually. As you've seen in the board packet, if you've done a pre-read, we're in a bit of an unprecedented situation in that the overall renewal for round 3 is a little bit higher than it was for round 2. So we'll have another version of the conversation that we had last month also, but with more options and more things to consider as we combat the 9% renewal increase and find a way to make a balanced package for our membership as we achieve 3.4%.
Thanks. I just wanted to mention there was a late filed bill, House Bill 2221, that would have amended the 3.4% statute for PEB and OEBB both to a 6-year rolling average. And we talked about it briefly in the last board meeting, so just wanted to let folks know. Unfortunately, it didn't make it past the cut, didn't get to a hearing, so it's essentially dead. So, yeah.
So today we're going to focus our time on, we're calling them financial decisions, but really it's a big package of decisions for our members to help achieve 3.4%. We have 4 different options to walk through with you, and all of the options encompass elements of our balanced framework: negotiation, efficiency, subsidy, and benefit changes. We thought maybe we would have one other thing to talk with you about, but thanks to Willamette Dental, we have that resolved for next year. We have a couple of clinical renewal recommendations from the CL committee to bring forward for you today. And then just a few pieces of information for you to share about some renewals that are going on in the background but didn't need any action from you today. And then at the end of the meeting, we'll assess next steps. We understand that given the magnitude of the renewal increase and the scope of the package of options that we're showing, it's a lot to digest today. So we want to make sure that we take our time and we're thoughtful about this and we answer all of the questions that you have available. So at the end of the meeting, we can assess and Bill can see where everybody's at and if we're ready to make decisions for next year or not. Okay. Rose, next slide, please. We always like to anchor with this slide. I like it too as we just approach these renewal discussions. Sometimes it feels like we have to spend a lot of time on the financials when really what we all want to do is improve health and outcomes for our members. Out of necessity, the premium and the benefits, they come with that and we have to talk about it. But by always coming back to the mission, vision, and goals, we can remind ourselves that we're here for a higher purpose. And just going through OEB's goals, they're new as of last fall from the retreat. And so many of them, we are going to be able to find a way today through our options to achieve these goals. So you'll hear about a solution called Garner later on today, which is under our efficiency aspect of our balance framework, and how Garner provides member education. It also increases access to high quality, affordable care. And amazingly, especially considering the renewal environment, it has the potential to reduce member out-of-pocket costs significantly. So you'll hear about all of that too later on in the day. And then, of course, OEB's mission and vision to transform healthcare and improve the lives of Oregonians across the state. And I know we all feel really passionately that when we can provide quality benefits and solutions for our members, that we're doing it. Rose, next slide, please. Thank you. So just to review the timeline, of course, we're here at our April 1st decisions meeting, but we do just want to highlight also that there's the flexibility to have in some form an April 22nd meeting if needed. It could be brief, it's virtual, so it takes some of the pressure off today. Mercer doesn't feel like there would be new information available at that time. Last month, we talked about the potential for looking at more experience later in the year to see if it was improving. It's become clear from claims trend that that's not the situation. So waiting for a fourth renewal calculation potentially makes this conversation harder. So there's no new financial information that would be available at the end of April. There would be no new clinical information either. If the board has questions that we can't answer today or just needs more time to think, that would be the one thing. But we wouldn't expect the options to be different towards the end of April. But we do just want to reiterate that flexibility.
Kirsten, I just wanted to also echo the fact that PED is going through the same thing right now, the same, progression with each round and, kind of uncharted territory. So it's not anything that's specific to OEB or like further research over the next couple of weeks could figure out a solution. So it's just that trend is just continuing to rise. We have to figure out how to get it down.
Next slide, Rose. One more. So let's take a look at where things are at. So as of round 3, the overall composite renewal increase now is a little bit higher than when we last talked. It's at 9.01%, which means that we have a gap of about $60.2 million to get down to 3.4%. And that's really driven, and we'll talk about this a little bit more on the next 2 slides, but it's important to mention it here too. What's happening is that we have high claims trend, and we have high claims trend nationally, and we have high claims trend in Oregon also, and within OEB and PEB. And there's lots of reasons for that. There's not just one reason. It's a confluence of lots of factors exacerbated by COVID, exacerbated by the economy and the difficult conditions that's made in the healthcare workforce, increasing prevalence of chronic conditions in our community that we haven't been able to get on top of yet, advances in treatment and new drugs. So lots of factors are coming together. And we have high claims trend, and the claims trend and the experience is exceeding what we budgeted for in last year's renewal. And so that's leading to an increase now that is higher than just a normal trend increase. Rose, next slide, please.
Before you go, so this is a request for next year. So I'm looking at the 9%. And when we do comparison graphs in the future, we're going to compare our 3.4% to market trend. I think the 9% is a better benchmark, or at least a separate slide, because if we just keep relying on 3.4, it's kind of disingenuous.
Yeah, you mean the renewal increase before all the changes?
Well, sometimes we do a timeline graph of the increases for OEB versus, the national market or whatever. And so I think this is a better reflection of where we are rather than 3.4.
Yeah, thanks, Robert. I understand what you're saying. Any other questions or comments? And
Go ahead. So I just want to put on the record that I guess my question is, and just to confirm, is that we have a cost within our system in healthcare because utilization of healthcare has increased. Have a issue at the national level that you can't control when it comes to pharma and the national trends. Because when we talk to our constituents or stakeholders and also partners like Moda, Kaiser, and Providence, and everybody else, I think we have to make it really clear why we've seen this increase. Otherwise, everybody's going to come back and they're going to think, well, we should have solutions to this when we're limited in some ways and based on revenue and support and what's impacting the markets too. So maybe we can clarify down through your slides and market section in minutes.
It's a really good question, and we've been thinking about this a lot over the last month. What can we influence in healthcare and what can't we influence? Because the unit cost for a service, that's really where we rely on our carriers and also Senate Bill 1067 to negotiate a reasonable unit cost and increase over time. But so many other factors are layered on top of unit cost. For example, one thing that is really a theme this year is acuity. So that's when people go to the doctor, are they coming for simple conditions or complex conditions? So we've seen for outpatient care and inpatient care also, leading into high cost claimants, more complex care, there's higher acuity. We also know that there's a higher prevalence of chronic conditions in our community too, and with our members coming in for care. And then also members are coming in for care more. So when we start to think about what are the levers that we control, for me personally, it gets a little bit tricky because 100% unit cost is something that we want to control, right? All throughout our personal lives and in our business lives and in healthcare also, unit cost prices must be reasonable. And that's been difficult with inflation in the economy. Senate Bill 1067 helps with inpatient hospitals that are subject to Senate Bill 1067, but some hospitals aren't. And then of course, pharmacy and provider services aren't either. So we have the unit cost piece. And then when we come to utilization, I think we have to be a little bit careful also, because maybe we want to control unnecessary utilization of care, but we don't want to restrict access to care. So it's a little bit of a double-edged sword, that one, because we want members to be going in for more care when they need it. And so maybe the utilization is going to be higher some years when chronic condition prevalence is higher. And then if members are coming in with more complex conditions that take longer appointment times and more follow-up services, again, we want those members to be getting treated. So what we're trying to do with our carriers is make sure that the unit price that we're getting charged is fair, and that we're not doing unnecessary services. But there's much of that that maybe we would choose not to reduce.
Yes, I do have just a little concern that, you mentioned COVID, and there was a lot less access to care during COVID, a lot of preventative care that was put off, and so we're still seeing the repercussions of that. And my concern with the growing trend of these rate increases, and because we are bound by that 3.4%, we have to make all these plan changes that make access to care more expensive, or not just continuing the problem, right? Like before it was access and now it's affordability access, or not forcing our members now potentially, or putting them in a situation where now they're putting off care that they need because they now can't afford it, and we're just kicking the bucket further down the road. And it really is weighing on me. It's very concerning to me, especially with these plan changes we're looking at right now. I sit face to face with our members all day, every day. My job as a benefits coordinator is to have those face-to-face interactions. And I often sit with employees and members who share really intimate details of their care, or the things that prevent them from accessing care, or that they're put in really terrible financial situations because of the cost of care. And I have to look them in the eyes this year and explain all of these plan changes. And this is going to be devastating. It's a really hard renewal to be part of.
It is a hard renewal to be part of. The benefit changes, the deductible increases that we're considering, and then also the nominal office visit copay increases. So mostly it's deductible increase. They'll be felt by members. We acknowledge that it's a tough year. When we talk about benefit changes, we also have an option that we want to talk to you about called Garner. And I'm going to jump ahead and give you a little preview of Garner because it directly is related to your concern, Sally. So deductibles, because of the 3.4% constraint that we're under this year, is necessary as part of our overall balanced framework to consider benefit changes, and because of the magnitude of the gap, the benefit changes are material. So we have options that look at a $300 deductible increase with a small office visit copay increase of $5, or a slightly lower deductible increase and then maybe a $10 office visit copay. So combinations in that ballpark. As part of an overall strategy that also includes negotiation and some other efficiencies, some subsidization with outside funds that we have. But then Garner, and we have representatives, Nick and Kirk also with Garner are here to answer any detailed questions that the Mercer team doesn't have the answers to as well. But here's how Garner comes in and helps with affordability. And the COUT committee met for 3 hours this morning to do a deep dive into Garner. So I don't want to give you the impression that what we're talking about here today is the only work that's been done on Garner. Staff and third-party partners in Mercer and Garner have been working for the last month, and COUT did a deep dive this morning. With that said, so the role that Garner would play is Garner is an app. It's a tool. It's an information tool. And when a member is going to go get care, if they look in the tool and find care for their tool, if they go to one of the providers that's recommended by Garner, then that member's out-of-pocket expense is reduced. And the way that we have worked on this with Garner is that the option that we're exploring with them, so we can picture in our minds, let's take the MODA 400 plan as an example. So the MODA $400 deductible plan might need to go to a $700 deductible plan in light of the 3.4% constraint. However, where the Garner program comes in is the Garner option that we're exploring reimburses $700 of that member's out-of-pocket expense. So effectively, it makes the plan richer than it is currently today. The first $700 of that plan are covered for an individual, and then $1,400 for the family. So there is some relief, Sally. It doesn't remove the conversation around the deductible increase, and your point and your concern is not lost. But I do just want to say that it's not in isolation, that there is something else for us to talk about that alleviates part of that financial pressure.
I do have some concerns with the Garner. Like, it's easy to say all of these, the wonderful pieces of it, but what I see is all the employees who now that's just one more obstacle to jump through. For a lot of members that aren't tech savvy or, are not really well versed in how to navigate their plans. I see it as an equity issue. In Lane County, we already have an issue with people being able to access primary care providers with MODA. A large part of that was with what happened with Oregon Medical Group. And people because of that, people were forced to find new primary care physicians and were running into roadblocks repeatedly with people not accepting new patients or not accepting new patients that had MODA. Or when they would finally find a new primary care physician, there was, a really long wait list to get care. So my concern is that will be great for people who can or have the ability or that skill set to navigate those programs or that new app or that new system. And it will be detrimental to those who can't. And have we looked at the access to primary care in Lane County? How easy is it going to be for people to find these efficient providers? is it gonna be one more roadblock and one more obstacle?
Yeah, they're all good questions, Sally. I think because they're deeper questions, and we have a couple slides further on that talk about Garner, and also we have Dr. Laura was part of our conversation this morning, and Robert was part of that conversation as well, and Enrique was here for part of it coincidentally too. So there are more people than me also, and I think your board colleagues, it'd be great if they could give their perspective too on some of these questions that you raise. And when we get to those slides, we can talk about all of the due diligence that's been done behind the scenes to look at access and how would we communicate to members, and what about members who aren't tech savvy? How do we not leave them behind? What about rural members? So all of the work that's been done behind the scenes, I think that we should highlight. We can do a mini review with everybody here on those major talking points when we get to that section. So we'll go a little off script and maybe go a little deeper than you were thinking to address some
Make
concerns.
sure that we have an adequate amount of efficient providers that people will be able to.
Yeah, of course.
Access, right?
Yeah,
Like,
100%.
yeah, I mean,
gotta see somebody.
Yeah, and just to reiterate about Garner too, the motor core network doesn't change. So it's still the same access to providers for in-net coverage as today. When we talk about network adequacy for Garner, what we're talking about is getting that incentive reimbursement. So in that way, there's some choice who you want to get it on your specialist, but maybe not your primary care doctor because you love them. So again, we should do a little bit of a deeper dive, I think, than we were planning to originally when we get to Garner.
To your point, I asked the same question earlier because the example that they use is chiropractor. So I use chiropractor. So then that's when I asked, well, what if my chiropractor is out of network? And they'll dive into explaining you're not going to lose your benefits. It's just more another step for you to get your reimbursement if you want to use this path. So I think it will be beneficial for the team who was here earlier, to provide that view. And what I appreciate about the presentation is visual. It's a map. It's interactive. Something that they haven't discussed is that they have a concierge system, right? Dr. Laura mentioned earlier that they need to be more bilingual focused, equity focused. I think that was an important highlight for me since we've been talking about that within this group. So what I'm saying is that the concerns that you have brought up forward were mentioned earlier, and I think it'll be best if they can do the same presentation, because I do want to make sure the board feels that they've been heard, but also the questions that they have, there's answers to them. If we don't, we're not doing the service to our board, because the other board will have a higher quality presentation or overview. So I think it'll be best for us to have that. I know time is an essence, but I think it's beneficial for all of us.
Yeah, let's do it.
Because I know at our last board meeting, I asked for, like, I heard all the pretty parts. I want to know all the ugly parts. I want to know where it's been difficult, what have been the obstacles, what are all the negative pieces, because I'm going to be the one that's helping people navigate this system. And I don't want to be caught off guard when employees come to me with issues. I want to know that those issues exist and have already discussed and had tools available for me to then educate our employee group, so that if this does become something that I can make it positive for the employees and it doesn't become a point of privilege, right?
Yeah, I think that's really good. So I'm thinking, Rose, let's skip ahead to slide 13. So we'll free up some time to do a Garner deep dive then. So what I'd like to propose is, let's understand, first of all, how are we thinking Garner even fits into the big picture? I think we need to know a little bit of the big picture first, and then we'll jump ahead to the Garner section to give that maximum time. When we're comfortable with Garner, maybe we could come back and tie it all together and see where we're at. That sounds good to people.
I'm just sensitive to what Sally had mentioned, and we're going to employ every resource that we have available to support you as board members, to support our members, our entities. I mean, everybody, this entire group here is just really here to support that and understand what the gravity of the decisions that are going to be made and the communications that are going to need to be created and just being out there and looking people in the eyes. And we've done this before. It's super hard, but you can lean on us.
All right. So we're going to do a high-level overview of the 4 options that we brought for discussion today, so we can just see where Garner fits into all of this, and then we'll move to Garner. And I'm asking the Garner team and then also the Mercer team from this morning. We can do like a condensed little mini, and Garner team, it'd be great if you could talk to Sally about some groups, the challenges that they've faced and things that you're aware of. And then the Mercer team, we can talk about health equity, member experience, access, and then we'll talk about the incentive too in a little bit more detail than we were planning. All right. So 4 scenarios for you. And what I want to do is start on the right and tell you what all of these options are. And we skipped a bunch of slides, so I'm going to give you that material while I'm also giving you this material as well, because we need to have in mind our balanced framework for achieving 3.4%, which has a foundation of negotiation, and we need negotiation with our carrier partners. So let's see where negotiation is in our 4 scenarios. So Kaiser Permanente is a fully insured contract, meaning when we negotiate with Kaiser, what's important is overall premium. So Kaiser's participating in the negotiation a few ways. One, they held their round 3 renewal, which was a little bit worse than round 2, about 107%. And then also Kaiser's offering an underwriting premium concession of 1.5%. which equates to $4.1 million. So that's the top row, is Kaiser's premium concession. So now we look to MODA. MODA is a minimum premium contract, which is different than a fully insured contract, specifically when it comes to what does the carrier keep. So in Kaiser's scenario, they're fully insured, they keep the premium, and then they pay claims. If claims are low, they keep the difference. If claims are high, they're out the extra money. But with MODA, it's more of a claims pass-through, and what MODA keeps is the admin. So when we negotiate with MODA, what's important for you is that we're negotiating admin, not the total premium. And so we did a couple things with MODA, and thanks to them for their participation in this as well. So OEBB was paying as part of their admin fee for a program called Nurse Line, which is a 24/7 nurse consult service. And we feel like that service is redundant because we have CRSMD in place, which is 24/7 consult also for urgent care. And it's a requirement of PCPCHs in the state of Oregon that they also have someone on staff who can triage calls 24/7. So this would be triple redundancy to retain Nurse Line. So we put this under the efficiency bucket or the negotiation bucket and recommend terminating Nurse Line. Quit for Life, QFL, because we needed it to fit in that box. Quit for Life is the tobacco cessation vendor. We're not recommending terminating tobacco cessation. But if you can rewind to a conversation we had last spring where we all collectively agreed that we should be paying per participant, not per eligible. So in this scenario, Quit for Life is currently a per eligible payment method, which means we pay no matter how many people are using it. Specifically, we're paying about $500K. The utilization is much lower. So by switching to per participant utilization-based pricing, one, we save money. And then we're going to pay for that through the claims. We didn't need to load for it because utilization's low. So it winds up being a net savings to us of about $500K. And then also MODA has agreed to a rate hold on their admin. So in round 1 and 2, MODA was asking for like a cost of living style increase to the admin as part of the round 3 negotiation. They agreed to a rate hold, which was about $245 PEPM or $1.3 million. So those are the negotiation items that are part of all 4 renewal packages. And then we go into the benefit changes. MODA margin is second to last, and then Garner. I want to go to MODA margin because it's related to something that we talked about. We calculate a premium for MODA, but because MODA is minimum premium, all MODA retains is the admin. So when we include a little bit of margin, what we're doing is we're making it more likely that it will come in on target for next year's renewal. We're adding a little bit of cushion to the renewal calc. It is actually the board's decision if they want to include margin and how much margin. Given the renewal climate and based on our conversations with you, we felt like you would tolerate a lower margin this year in an effort to avoid more benefit changes for next year. So that's where that MOTA margin comes in. There's about 6 million total available in MOTA margin. We don't want to completely sink ourselves for next year, right? So we're leaving a little bit of margin available, but we are using some to help achieve 60.2 million. We have a section for benefit changes. I'll talk about those too. Garner is the last row. So you can see with the Garner option, the way it's currently configured, and there's a lot of flexibility, but the way that we saw it coming together for you, Garner would bring about $8 million in savings towards that 60.2 million. And then for the benefit changes, for Kaiser Permanente, adding the coverage for artificial reproductive technology up to the current benefit maximums, which we've heard from you all before as being a priority, is only 0.1% of premium. So we felt like maybe you guys would like the trade-off of, since we're already taking benefit changes, taking 0.1% extra on the benefit changes to be able to expand family building coverage. The Kaiser dental benefit change is an out-of-pocket maximum change from $4,000 to $3,000, which is still higher than all of the MOTA plans. And then the MOTA benefit changes and the Kaiser benefit changes, those are the medical deductible changes. And then in one scenario, scenario 4, which is not necessarily a recommended scenario, but we did just want to show you the flexibility that you have. The Garner savings would be used to fund the addition of artificial reproductive technology coverage to the MOTA plan, as opposed to mitigating the benefit changes a little bit. I know it's a lot of information. On the next slide, what I just verbally went through for you is all written down in there's a big list of what are all these things and what do they mean, so you can see that. And then also there are maybe 6 or 7 slides with all of the benefit changes too, and we can go through that in detail maybe after we get through the Garner stuff too, depending on how you guys are feeling. But maybe I'll stop there and we can just take a minute and all look at this together, and I'll give you some time to think of questions that you have. And then we'll move on to a mini Garner presentation.
Quick question on the Kaiser carrier credit, 1.5%.
Yes.
That'll have to be picked back next year.
Yeah, one of the slides we skipped, Georgiana, thank you for bringing that up. One of the slides that we skipped is a slide we've seen before earlier this year, and it talks about the disadvantages of subsidizing rates. So when you underfund your premium in 1 year, then you expect to have to pay it back the following year. And in fact, part of the premium increase for Kaiser this year is because the rates were subsidized last year with RSR to help mitigate benefit changes. So that's why the subsidy amount is only 1.5% and is not more, because we're trying to not put ourselves in the position of repeating this exact conversation again next year. Yes.
So last year when Kaiser's renewal percentage came in high, and they had all kinds of discussions with us about initiatives that they were taking so that that didn't happen again this year. And then this year it came even higher. What is Kaiser saying about next year?
Yeah, and Jennifer Stacy's here from Kaiser, so I'm gonna let her speak on behalf of Kaiser. Jennifer, did you hear Sally's question?
Yeah, I did, thank you. So, acknowledging this is not where we wanted to end up by any means. Medical trend is coming down, actually, 25 to 26. What has gone up very significantly for OEB is utilization, right? So year over year, we saw very significant utilization increases, about 16.9% claim increases. And so, while medical trend is being controlled, particularly through the many cost-cutting measures, workflow, all of those things that we've been implementing, just providing more care to Kristen's point, higher acuity, by taking care of the members, we've just simply incurred more claims this year that require a higher renewal to be able to continue to provide the ongoing care that we're seeing.
And so what are your thoughts potentially about next year? Do you see a renewal percentage increase coming in similarly to last year and this year?
What we see is a lower medical trend overall. Utilization, I think, still remains, as Kristen mentioned, we saw continued increases in utilization. We want to provide that care to people that need it. And we have been focused really hard on improving access, because to your point, access in Oregon and Southwest Washington has been constrained. It's hard to say at this point what it'll look like. I don't expect it to be that high because we have driven down the underlying medical trends, but ultimately we'll have to look at utilization and all those things we can put into place to make sure that we're providing the care at the right place, right time.
Yeah, I mean, I definitely don't, want access to care provided to be reduced. But, just questions about, this year was one unexpected, is there kind of more work, research or whatever? I don't know, I don't do that job. Being put in to kind of look into next year, like learning from last year and what we didn't know that happened. Are we doing more work to have a better idea for next year?
Every day, in every way we're looking at how do we drive affordability more effectively. One thing that we talked about a little bit when I came a couple months ago is, part of the increase in overall care, and this is overall, but we've got genetic therapies that are going really through the roof as far as the pricing that pharmacy can bring to the table. So we continue to look at that to make sure that we're providing, because you want to provide it, right? These are life-changing genetic drugs that support, whether it's an infant that is missing an enzyme or whatever. So we're working through that to make sure we can provide those right place, right time. We're looking, frankly, at weight management. So overall, when you look at Kaiser Permanente Northwest, about 44% of the increase in demand that we've seen, which currently demand is higher than it was before pre-pandemic. So the highest we've seen in, 5 years or more. A lot of that is driven by people having weight management conversations, even without weight management only drugs being covered, because we've got so much chronic condition, that type of thing. So we're looking at how do we work through clinical pharmacists and nutritionists and things like that to be more effective there, to drive that care in the right place, to keep primary care open. We continue to work for behavioral health, both access and to put that in the right place by co-locating behavioral health specialists in primary care. So it's really at every aspect of the clinical care system that we're looking at how do we drive more effectiveness and efficiency. And I know I talked a little bit before about AI. And so, we introduced ambient listening into all of our clinical spaces. That's helped us drive more physician efficiency, as well as capturing more effectively the notes and all of that kind of thing. So we continue to see that drive and have rolled that out to more physicians. So there's not really one magic bullet. But we have an entire value and affordability operation that we're looking at that's, constantly generating more ideas and vetting more ideas. So there is a real commitment, and we are seeing a significant decrease in medical trend from this year to 2025, because we're still talking with the 2025-26, but going into 2026. So that piece is working, but it's still that utilization piece that we're also focused on.
But isn't it also the case that your fee schedules are going up as well?
Yes, fee schedules did also increase because of just the cost it takes to provide
So
care.
it's not just strictly utilization.
Yeah, that's accurate.
And then how much of it is utilization versus the fee schedules? Because the fee schedules are something that Kaiser controls, right?
Yeah, the fee schedules, KP has fee schedules, just like all organizations have fee schedules that you have to adjust to be able to cover the cost of the service provided. I can give you some information around just utilization increase. I know that's what you were asking about. So
I was asking about fee schedules, not utilization increase.
yeah, I will have to come back to you on, parsing them out. I think
So I think it's important for the board to understand the impact of both of these things. Because it's not just strictly utilization, it's also what you're paying for each unit of utilization. And so I think it's important that you have the whole picture.
And if you have a scheduled out, forecast 2 to 3 years out, if you already have that in your system, then I think we'd like to see it, because then that will help us forecast and, see long-term costs.
Yeah, we set these schedules year by year. So they, like I said, they did go up. I don't have at my fingertips right now each one of them. They are remaining more flat in 2026 going forward. So that's as far out as we have them. I can tell you, I'll tell you a part of the story and then we can get back to the others. But within the increase that we have on board here, you'll see outpatient visits, the utilization increased. So when you're talking about lab and radiology, about 11%. We saw video visits increase almost 12%. We saw length of stay in the hospital increase by 20%. So those are the types of increases that drive from a utilization standpoint. And then I hear your ask around it.
It's part of the story, it's not the whole story.
Yeah, and then that's why I said I'll have to get back to you on it. I just wasn't prepared for that question. Thank you.
Yes, also we have Michelle with her hand up too. So Michelle, you want to go ahead and ask your question or your comment?
Yeah, thank you. I was wondering if all OEB members have both Kaiser and MODA plans to choose from.
No, Michelle, the service area for Kaiser is not statewide, and then also each individual entity has the ability to choose their own set of plans from the full portfolio of 11. We have that information out in our open enrollment report from January, so we could always look, I think, behind the scenes and let you know. But the short answer is no.
Okay, thank you.
Could I ask a follow-up question to that, please?
Yeah, of course.
Yeah, so I live over on the coast and I go to the I-5 corridor for all of my medical services and would like Kaiser as an option. Why is Kaiser not an option for the coast?
Thanks, Misty. I don't know, Jennifer, if you want to speak to that now, or should we get back to Misty later?
Yeah, our service area is driven, there's regulations that require us to have certain network adequacy. And so we can only offer to certain zip codes where there's the overall network adequacy available, and completely understand that different people have different perspectives and drive times and that stuff about what network adequacy would be. But there's, regulations that prevent us from offering, offering health plans where we don't have a level of network adequacy available.
Okay, who sets those regulations?
Oh, I think there's both federal and state, I believe. But I can get back to you and have those specific.
Clarify, what do you mean by adequacy? Are you talking about like access to all, or, I guess I'm stuck with that word. What do you mean by adequacy?
There's different levels of requirements for how, like, many providers within a certain miles from people that are available. So there's just adequacy requirements where they're defined, whether it's, Social Security has certain adequacy requirements, state has certain adequacy requirements you have to meet. So it's like the providers that a person can access within what is deemed a reasonable. Okay.
It's like the access limits
Okay,
that
thank
we
you
talked
for,
about in the morning, yeah.
And I guess for Kaiser, one more, I'm sorry. I understand where you're coming from on your explanation, but I've been on this board for a couple of years, and we were having a big picture discussion and within my organization and when I visit members. But the other thing that I've been hearing from Kaiser directly, it was not your team, but a different team a couple of years ago, was like, well, we're not going to make money in Eastern Oregon or outside the I-5 corridor. And I'm sure that's part of your business model. So I think you'll have to add that to the conversation, because you are ultimately a business, although you consider yourself a nonprofit. I think we have to be really honest about your cost and effect, and it's going to cost you more money to put a hospital or a clinic in an area where most of your clients are not going to go in a high, compared to a high density area. So I think we have to be honest with ourselves that it is a business model that you have, and your rate of return and money in the rural areas is not the same. So I think I would encourage all of us to, and your team to talk about that then, because we can go back to the governor or our legislators and say, hey, look, Kaiser is saying this, so-and-so is saying this. What can we work together as an organization, as a state, and with the business community to build a small clinic so they can feel they're also making money while our members are getting the access to healthcare. So I think I would encourage you to add that to your concept, because we, I have to have the conversation with our members, but if we're not hearing that from you, then I feel that Kaiser's switched their posture and their concept of what is access to healthcare.
Right, and to double down on that, we went through the Garner presentation this morning, and they showed the lack of different healthcare providers in rural areas in Eastern Oregon and all of those things. To me, this is an equity issue. If I'm willing to drive 50 miles to seek healthcare, and I'm paying into OEB, why is Kaiser not an option for me if that's where I want to invest my healthcare, benefit? I guess I need a better explanation when I can just drive to Salem, which is where I'm going anywhere, and visit a Kaiser hospital. I'm not asking for Kaiser to build facilities on the coast, but if we're driving anyway to get the healthcare that we need, why can't we have that as an option?
I'll come back with the network adequacy information.
It's a law.
Yeah.
It's a law.
That's a regulatory issue.
It's a legislative issue that needs to be addressed.
Well, if it's state, we can't.
It does, because, as an educator, I should be just like every other educator in the state with this benefit. So, why does half of the population get to access that on the I-5 corridor and we don't?
And Misty, you probably didn't see but Jennifer Stacy mentioned that she will work with her regulators and get you a more complete description if it's federal or state regulations or both. And then I know I heard Robert too, if it's a state regulation, perhaps you all have some more flexibility in that respect to change things.
Great, thank you. I just need more information. I need to know who to, drive this up the tree, so to speak.
Yeah, 100%. Okay, so let's take a little detour to Garner, and then we'll come back to the main road. Garner teams, what I would like to do. Rose, if you could go to slide 23, please. We'll use that as our starting point, and then I think the order of operations, we'll have Ian talk about how top providers are selected, and Ian can talk about health equity, and then we'd love for CL committee members to add insights from this morning. Next, Andrew, if you don't mind, you can recap your access presentation from this morning and tell the board what you found, and then similarly, if CL committee members could add feedback. Garner is available. We'd love to have Garner do the member experience demo for you, because it's very short and it's powerful for you to be able to see with your own eyes what the user experience is like. And then you can come back and see what lingering questions that you have. There was a lot of material presented this morning, 3 hours worth, so we have a deep well of data to pull from if you have additional questions. But let's start at like the 20% level and see how far that gets us, and we can always come back and go a little bit deeper as needed. So this slide highlights the member experience from provider selection to member reimbursement for out-of-pocket costs. The member experience starts with either the Garner app or the phone concierge team, and some feedback from this morning was that it'd be a really winning situation if it was a dedicated OEB and PEB concierge team who were specially trained on OEB and PEB's unique benefits and situations. So members can call and get phone support as well. When they use the app to search for care or talk to the concierge, a top provider is going to be recommended to them. This is a provider that meets the quality standards, they meet the cost standards, they're accepting new patients, and they're within the driving distance for where that member is located, the driving distance standard. So the provider has cleared all 4 of those due diligence hurdles in order to be recommended by Garner. I'm going to pass it off to Ian, who's going to tell you a little bit more about top provider selection, and then also Ian is going to talk a little bit about health equity as well. I'm wondering if we should wait for Sally. Yeah. We'll just wait a minute for Sally.
Well, I can just provide some quick background, while we're waiting. So I think, essentially what it does is it's providing you an incentive. So if members choose to use a top provider and then Ian will explain how top providers are selected. If a member chooses to use them, a portion or all of their out-of-pocket costs will be reimbursed. So that's really just the basic concept behind Garner, up to a certain limit that the board would set. So that's it, and then we'll go through the various other pieces now.
Okay. Thank you. So what Garner will do is basically, take advantage of big data and analytics. So they're leveraging about 75% of what is available in terms of claims data and creating practice patterns. So as a physician, I practice a certain way, and that can be gleaned from claims data. And they're looking at quality as well as cost. So we're really trying to get to value. So in a way, it's teasing out within the core set of providers, identifying a layer of information and identifying what we're calling top performers based on a score that's the intersect of quality and cost. So basically that's value, right? It's not driving towards the lowest cost, but that performance score quantifies and identifies a subset of those network providers that are achieving the optimal value. And the things that are being measured from a quality is about 530 currently. They'll continue to grow as our knowledge and standards of care continue to increase. So that's a big aspect of it, is the quality piece. Some things are basically appropriate care or unnecessary care events. So those are things that we can measure and count from claims. Then there are things related to utilization intensity. So that's a big part of the efficiency aspect. It gets risk adjusted because some of that is driven by how sick that patient is or the complexity of their diseases. So that gets statistically factored in. And the other one is outcomes. Right? So out of all this, ultimately we want good positive outcome. And then all that rolls together into a top performance score. So again, it's not a narrow network, it's just identifying a subset of your provider network that have been quantified through this algorithm, plus the other factors, right? Are they within proximity that's acceptable? Are they accepting patients within the reasonable time frame and things like that? And then serving that up and making that transparency visible to the member. So really it is about the need to engage members and moving them from a passive to an active healthcare consumer. So I would say that's a prerequisite for this in terms of optimizing and taking advantage of the information that's being presented. As a byproduct, there's some financial benefit to the member, as Kristen had mentioned, because the efficiency and the value that is generated, they're getting sort of the reimbursement back in terms of their out-of-pocket. Let me pause there. That was a quick overview of what we kind of went over in the CL this morning around the top provider algorithm method.
And I apologize if this has been covered before, but how does this play with PCP 360, or is it in place of PCP 360?
I think Georgianne, was it you? This question came up in CL this morning
Okay.
also.
We're on the same page, so.
Yeah. Do we know?
Yeah. Erica, do you want to answer?
Yeah. Just higher, positive high. The question was, how does this interact with 360? Yeah, so it's going to sit on top of it. So the 360, members will still select the PCP 360. And if they do, or if they utilize 360, we'll attribute them to that provider, and they'll be in the coordinated care plan. And so that'll still work the same way that it does today. This will sit on top of that. And for those providers that Garner has identified as the most efficient provider, then those are the ones that will get the incentives. Though that is a conversation that we do still need to have on the specifics of how that will work for all PCP.
Yeah, because if somebody's PCP 360 is not one of the efficient providers.
Right. Yes,
then
and
for them to get that, they would have to switch to an efficient provider. Are all efficient providers going to be PCP 360s?
they wouldn't be, but
Okay,
this
so
is a
sometimes
conversation.
you'll have one or the other, or both, or just one, depending on.
Yeah, and this is the conversation that we need to have with Mercer, because Garner is able to, how do I say this? Is able to accommodate different requests. And so this is a conversation that we need to have with Garner on how we want to treat PCPs.
Yeah.
So I completely understand your question. It's a great
Clear
question.
as mud.
Yeah, the one that came up today. So that one is something that we need to discuss in more detail.
Yeah, I think, as Erica mentioned, you have a lot of flexibility because they're a new healthcare startup. They're not brand new, they're stable. But they're new enough to be nimble and flexible in what they're able to do for you. And so we do have the ability to look at, is there anybody that we want to make exceptions for example, all primary care? Just need to do it thoughtfully with the big picture in mind. But the customization is available, and we'll definitely look to you all for your input on how that would work. I think it will be more clear to you as we especially talk through the network adequacy and access information and how that fits in. It will become maybe more clear if you have questions or preference about that.
And so if I understand correctly, I'm looking at you only because you said chiropractor earlier. Efficient providers aren't necessarily only primary care physicians. They can be specialists. So like you have your PCP 360 and then you need a chiropractor. You can pick an efficient provider for your chiropractor and then get that reimbursable care benefit while keeping your PCP.
Yeah, in our dream world,
Like,
we've
so it's
done-
kind of a,
Yeah.
it's an a la carte-ish.
No, I think of it more like
Option.
a new
Yeah.
habit. A new habit we want members to adopt whenever they are going to go get care. We want them to be in the habit of opening up their app or calling the concierge and saying, okay, who should I go for? And you'll see in the user experience that the app is not a painful experience. Texting with the concierge team is not painful either. It's like you open it up and, the way you would check your bank account, it's a similar style of intensity of experience. So through our communication efforts between staff and MODA and Garner and you all too, everybody's joint communication efforts, really want to make sure our members understand, hey, all I have to do is open or call and search for care. And I'm going to be in the habit of doing that every time I need to get care, not with the same provider, but for a new kind of care. And it's a choice. Go ahead, Cheryl.
So does this mean that each time you were going to select or needed a service, you could be visiting an entirely different provider every time? I.e., you go to your PCP 360, but maybe there's a more efficient PCP 360, so we're going to go over here, but then I need to go to the chiropractor. And so this chiropractor Garner has selected to be more efficient, so I'm going to go there. The next time I need to go to a chiropractor, maybe I'm the kind of person that goes every month. Am I going to go back to Garner and look to see who's more efficient each time? Or do we, because I think that's one of the things that providers,
But you don't have to.
I mean,
You're
people
assigned
will
that.
want to have a regular provider and a regular person to go to and not.
Yeah, it's just for a new type of care. So if you were going to initiate physical therapy for the first time or initiate chiropractic care for the first time or therapy, then you would do your search And the way Garner tracks you is they've tracked that you've searched for that. So then every top provider in their system who provides that service is pinned to you. So now there's nothing else you need to do. You just go make an appointment. When MODA sends the claim feed to Garner, Garner's going to recognize, oh, hey, you searched for this provider and we've pinned them to you. So now you're going to get a reimbursement. And you didn't have to do anything on that. You just had to search for that type of care.
So it is possible when we first begin to use this program, or any of our people begin to use the program, it is possible that we could be switching up a provider that we've used that was covered as a in-network care, but you could be switching that up to somebody else because they're more efficient.
If you choose. So the plan changes, unfortunately, because of where we are in the renewal increase. Achieving 3.4% is going to require plan changes really across the board. And there's no change for the underlying core MODA network. So a member is always free to keep their PCP relationship if they want. If the PCP was not a top Garner provider, the members co-pay for that PCP. So $25, $30 would not be reimbursed. But let's say now the member does not have an established relationship for their next kind of care they need. Maybe they need physical therapy. So they go to the app and they search for physical therapy and they use one of those providers, and all their cost shares are reimbursed for that course of physical therapy. So members have some discretion. The incentive amount that we're looking at with Garner is $700 total per individual, $1,400 per family. So you can kind of think about it a little bit as a reimbursement budget, which is, okay, you know what, I want to spend my reimbursement budget on my knee surgery, and I'm going to keep my PCP. Or maybe for me, I know I'm going to have some other type of care this year, might have a lot of out-of-pocket costs, so that's where I'm going to really focus my Garner effort. So members will have some choice and flexibility that way. Always the underlying core network is the same. Always it's a choice.
I just want to add that earlier I had a similar question, and Bill came in as well with this similar question, and my question was, you know, if I want to pick my chiropractor or why not, and the way I heard it, and maybe I'm wrong, but I heard that the people who are providing a quality care or a certain metrics that they're using to elevate those providers will benefit the members, but also it's not on our members to rate those providers. And this system would allow us to find, because they have a map, right? When you type in your zip code, it comes up with number of providers available to you with the rating. And the other question was like, well, what if they can score 70 or 80? Well, you know, they're not there. So for me, this is a useful tool based on what I heard this morning on finding that quality care or the good sort of quality experience that you're looking for. But also the other piece that I've made really clear, and that I think goes to your point, is like our members are going to struggle, so we will need communications.
Yeah, lots of it.
You know, I said I represent 42,000 members, right? Some are in Kaiser and some are in MODA, and it's going to have to be a communication of accuracy and patience, and having the support staff to implement this. And I appreciate what Bill said. It's going to take about a year to turn around and educate the membership. So I think if we're going to approve this, which I think it's a good model that we should be thinking about, we should think about as a board how we want to communicate with each other, because you and I know our members are going to be like, why do you make this change? You know, so I don't want to be the other end. So I won't be calling MODA and Kaiser or whoever, right? So that's the request I had earlier with staff to your point. I will need help, or do a YouTube video, or do a tutorial. So, and for the record, I don't work for, where are they? They're right there. I don't work for them, but I have the same issues, you know, who I work for, who I represent, but I understand the question. So I want to make sure you all understand that your peers before you were having the same dialogue, and I appreciate that you bring, because it makes me feel like, okay, I wasn't shooting arrows at people. I'm not the only one, so you know, I was nice, but you know, I appreciate you coming up with the same questions I had earlier.
I think with other initiatives in the past, I think as proactive as we can be, you know, getting out there, getting the message out, rather than them learning about it on their own throughout their own process has been more effective over the years. Yeah.
And Garner will come to your school district, Sally.
I know I ask a lot of hard questions, but Voda and Kaiser have been wonderful. And anytime I need help, they're right there answering questions. Like, there are many wonderful things that I have to say about Kaiser and Moda. So here I'm going to ask the hard questions, but I do appreciate you all. So you know.
Thanks, Sally. Michelle, I think your hand is up again. And Samantha too.
Thank you. I have a couple of questions and apologize if I'm retreading ground already covered in the CL meeting this morning. So one of my questions is how providers, like what is the provider experience of becoming a Garner approved provider? Like, I'm worried about incentivizing providers to provide less care so that they can qualify for this Garner status. And the other thing, like, about being, giving people choice and making sure they're an active consumer, I think in this context is pretty meaningless, because when you go to a doctor, you don't know how much anything costs. Like, you don't know, like, there's no discussion in the doctor's office, in my experience anyway, of like, the doctors don't want to talk about money in that space. They want to talk about what type of treatment you need. So the choice that you're making happens before you even get into the doctor's office, and then all the cost is like in this black box, right? You find out basically when you get the bill. So I'm not very persuaded that this is like going to be great for members because they have more choice. And then finally, I'm wondering why is this a reimbursement model? Like, why not just make it free or cheaper at the point of service?
All right, thanks, Michelle. Let's take those in order. So I'm going to ask Garner first to address the provider experience, and then we'll come back to your question about being an informed consumer. And then, Garner, if you have a thought about the reimbursement model also, you could add that.
Absolutely. Yeah, so to start with that first question, I think that's a great one, really important. We have no provider contracts whatsoever. So it does not behoove any provider to kind of go up in the Garner rankings or go down. We don't get paid by which providers are recommended by Garner or not. The only reason that we are recommending providers is based on how they're actually practicing medicine and those cost and quality metrics that we look at. So no financial incentive whatsoever going between Garner and the providers that we recommend. Want to make sure, does that cover the first portion of the question there?
Michelle, does that answer your question?
Yes, thank you.
Yeah, and I would just reinforce too that we are not steering towards doctors that are just reducing utilization. There's a number of different metrics that go into play here. Like, hey, somebody might be qualified for spinal fusion surgery because their own presenting condition would actually be determined to be like a good clinical pathway to get spinal fusion. That's great. We don't want to get in the way of that. But what we're trying to do is curb excess utilization like a spinal fusion for a member that really should not be getting a procedure like that too. So in some instances, we are looking at metrics of like, is that doctor doing, in all instances, is that doctor doing the right thing from a clinical appropriateness perspective? What are their outcomes? I think maybe Dr. Trang was going to talk about this too. What site of care decisions are they ultimately leveraging as they're determining whether to send somebody to an ambulatory surgery center or do something inpatient? So on and so forth. So it's not truly looking at are you limiting services, and that's what's driving down costs. There's actually a pretty robust set of metrics that we're using to sort of govern whether or not that doctor is ultimately denoted as a Garner recommended doctor too.
And then to that second portion with cost for employees, so we agree that can be a really confusing experience, not understanding sort of how much you're going to be paying when you walk into that doctor's office. Which is why for us, anytime someone goes to see a Garner recommended provider, 100% of that out of pocket is going to be covered. So whether it's going to be that $43 visit or that $60 visit, anytime a member is visiting a Garner recommended provider, they are reimbursed at 100% for their out of pocket. And that includes the office visit, prescriptions, labs, imaging, surgery, anything that's related to that episode of care.
Yeah, I think what we find is that if we can get to an employee at the onset of the episode or their family member at the onset of the episode, like they're going to listen to what their doctor tells them to do. They're not going to want to go shop around themselves. So like what we, I think, really lean on is we know based on data, what are those doctors' behavior patterns, what are their typical outcomes, et cetera, so that we're not making the employee throughout that episode have to make decisions. The doctor is making those decisions on behalf of the employee, and that will ultimately result in improved cost of care for their episode downstream. So really trying to take that decision-making out of the employee's hands after we steer them to the rendering physician for the episode of care.
Do you have any thoughts about the reimbursement model versus point of service reimbursement?
Yeah, absolutely. So reimbursement model is sort of our standard on how we work with large employers like OEB. So again, 100% of that out-of-pocket expense is going to be given back to that employee or that member up to the incentive amount. We do have certain organizations that we work with where we kind of create that essentially Garner plan. It's something that we'd be willing to explore for future iterations here. But for right now, that reimbursement model is what we've seen to be really effective at driving engagement.
Yeah, so the nice thing is this would sit on top of all plan designs that OEB is offering right now. It allows us to very seamlessly do that with both OEB with MODA for OEB, and then for PEB, same thing with MODA and Providence. The reality is if we would set up some sort of design that was ultimately adjudicating at the point of service, that takes a whole lot more effort with the health plan to set up claim design adjudication at that point of care. Having this just sit over top of it as a reimbursement mechanism is a much easier program to launch, and frankly, pretty easy messaging to the member as well, regardless of which plan design that they're enrolled in within the OEB portfolio.
Michelle, did that answer your questions?
Yeah, one follow-up is just like how, what is the member experience of applying for that reimbursement? I just want to make sure it's not a really complicated, like involving faxes or, a lot of barriers for members.
Yeah, no member work needed whatsoever. So the only thing that a member has to do is perform a search to find the provider. Then we see on the back end that the individual has actually seen that provider because we set up a claims feed directly with MODA, and then we reimburse that member automatically. So no taking a picture of the EOB and sending it into Garner, anything like that. It would be a really seamless experience for that member.
Okay, thank you.
Nick, I feel like now would be the right time
Yeah,
to
great.
remember
I might sneak right next to you here just for visibility's sake.
Samantha, did you have a question? Sorry about that.
Yes, I did. I wanted to expand on the member experience. So I want to know if when searching for a Garner recommended provider, will it always be guaranteed that it's a provider within the Connexus network, or is there a chance that there will be out of network providers recommended?
No chance. All within the Connexus network.
Okay, that was my question.
And I think that's a perfect segue into kind of the live user experience here. We just wanted to ground us in exactly that message that we would be sending to members. We want this to be thought of as very simple. Again, we want this to be non-disruptive and hopefully not taking anything away. So the message to members is really use Garner to find the highest quality doctor that you have access to, see that doctor, and then you'll get reimbursed automatically. So this is the simplicity of the member message to the member. Number of different ways that they can get into the Garner program through that direct link that we will be setting up with MODA, as well as just through our desktop, our app experience here. And when they do get in, this is going to be the experience that they see here. So we want this to be clean. We want it to be simple. We want this to be very directed in the number of things that I can do as that member. You'll see, because this is dummy data account here, demo account, this is my first time logging in. The first thing that I'm prompted to do is set up direct deposit. So to that question on member ease of use and that reimbursement, our standard, if someone does not set up direct deposit, is to reimburse them through a check. Typically arrives before you receive your EOB in the mail. But setting up direct deposit takes 60 seconds and then just creates a little bit more efficiency in that process. So really don't have to think about that as the number. The first thing, and where most people are going to spend their time, is in finding a provider. So I can search for a PCP name. Let's say if I wanted to see if that PCP relationship that I had was considered a Garner recommended provider. I can search for specialty care. So here I'm looking for a cardiologist. And to your question earlier, Sally, this is for anything outside of emergency services. So including mental health, including physical therapy, we've got about 82 different specialties that we can service. But the example that I used before, back pain here, let's say I'm experiencing some back pain. I know I sit in Portland. You can click to find care. First and foremost, we want to make sure that people have seen their PCP. So driving into that PCP 360 experience or just prompting them to find the right primary care provider first and foremost. What's going to come up are a list of providers that follow a few different rules. So to that question, all of these providers would be only within the Connexus network. We're never surfacing out of network recommendations. Then all of these providers here, you can see we've got about 15, 20 different recommendations. This is all I have to do as that member. I can go see any of these providers that we are recommending, and then I would get that reimbursement on the back end. So the reason that we're recommending these providers here, these non-surgical orthopedists, is because they are outperforming their peers from a quality perspective, as well as at lower costs compared to their peers. The last reason that we are recommending these particular providers is because we know that they have upcoming appointment availability, as well as are accepting new patients. We're trying to solve for that access issue as well. So if we click into one of our providers, let's say Dr. Christ, we can read a little bit more about our methodology. So we can understand why Dr. Christ is considered a Gartner recommended provider. We could go very deep into the methodology for any interested member. But ultimately, all of those 500 different metrics really bucket up into these three areas around diagnosis, treatment, outcomes. So just making it a little bit clearer for members. And then we had searched for back pain. So if it was shoulder pain or knee pain, we might be surfacing a different non-surgical orthopedist for that particular episode of care. Now, two other things that we had covered that I want to make sure, and then I'll pause and open it up for questions. So we know that you have rich benefit design and a lot of offerings for your people, for your members. So we want to be a part of promoting that ecosystem and integrating with that ecosystem. Here at Gartner, we have access to Bend Health. So just as an example, you know, if someone was searching for mental health, having Spring come up first and foremost, or other point solutions benefits that are available to members, and being able to drive them into that experience, show them what's available to them as well. You'll notice we have for therapists right now, online booking and virtual appointments. So creating access from a virtual perspective, regardless of where this member is logging in from or where they're searching for care. And then the last thing that I wanted to touch on is our concierge team. So I know that there was question around equity. The entire Gartner program here and all of our communications are fully translated from English into Spanish. So I could go through this experience in the program in Spanish, as well as our concierge team. They are all Gartner employees. They're US based, and we employ English and Spanish speaking concierge team members.
Are they unionized?
I'm sorry?
Are they unionized?
No, not unionized. No.
Maybe ever requirement.
We'll keep it a little more simple here. So for this, I can message in directly to the concierge. This is a pretty common example. This was a real example. I was looking for a doctor recommendation for my wife. I had gotten a recommendation from a friend, was wondering if they were actually a Gartner recommended provider. They were not. So the concierge was able to find 3 additional providers that are Gartner recommended, again, in network, have upcoming appointment availability, and are reasonable driving distance to where I'm calling in from.
And just to reiterate, this is all available telephonically too, not just via chat.
So I know kind of quick user experience, but I'll pause and see what questions we could answer.
Okay, Michelle, do you want to ask your question, then Lisa, and then Sally?
Sorry, my hand was up from before.
Okay, no worries. How about you, Lisa?
Are there adequate providers in the Eastern Oregon area, or is this more going to benefit the Central Oregon school districts?
Yeah, it's a good question. We talked through access in detail this morning, and I'll ask everybody to kind of comment on that too. And I know, Andrew, you're a little bit closer with that, but there are existing areas of the state of Oregon where we don't have access, in particular to some of the subspecialties as much as we would like. For example, in Southeast. Wait. Okay. So I think
move on.
Board members.
Yeah.
Just Samantha wasn't either.
Who's Samantha?
Right, okay. Yes.
Michelle, I think, had asked the question, I didn't hear that it was necessarily addressed, but why have this model instead of keep deductibles lower? And why only 2 members under a plan? So a family of 4, only 2 would be eligible for that?
What do you mean, Sally?
Is that not correct?
Can you ask your?
Would it be all members under the plan?
Yes.
Okay, sorry.
All members under the plan.
Okay.
So then a family of 4 that has to pay 3 deductibles, it would be 700, that'd be $2,100 per family.
Except, so the
the
Garner
reimbursement
incentive is, so as an example, could be 700 for an individual on an individual only plan, and 1,400 for a family on a family only plan.
Okay. So
However, to maintain equity for families, when we worked with your carrier partners on the benefit changes, there is a benefit enhancement embedded in all of this, which is that the family accumulators for deductible and out of pocket would all go to 2x, 2 times the individual, which is an improvement from today, so that they would be in alignment with the Garner incentive, so that there's equity between individuals and families and how that incentive is applied. So we haven't gone into details in the benefits yet, but there is an enhancement embedded in those changes that impacts the family deductible and out of pocket. And it's a substantial improvement for some of the plans.
And I'm, again, just curious why adopt this model and not stick to deductibles as they are. That gotta ask the hard questions. There must have been a cost analysis, like cost benefit analysis done, and that this somehow does benefit MODA, right? Because you are going to have the people that utilize this, but you're going to have plenty of people who don't utilize this. And so all of those people are still subject to those higher copays or deductibles, sorry.
Go back to
and
the
they're
core
paying.
scenario, because I think you have it backwards. This is reducing the monthly cost by employing this.
If Rose, could you?
Deductibles are increased, correct?
Increased less than they would be without this.
We'll see, let's look at the financials, it will help to see it. If we can go to, if we can go to slide 13, Rose. So let's look at a couple of amounts. So I'm gonna advance, I'm gonna put my.
So Garner saves. I see, okay.
It's across the board, so everybody saves because of Gardner, if we put Gardner in, right? So.
Yeah, so here's how it lines up. The Garner savings alone are not enough to completely avoid benefit changes. So some level of benefit change is required. We looked at a $200 deductible option and couldn't get there financially. The next lowest available deductible option was $300 deductible increase for Kaiser. Kaiser's is a $400 on plan 1, $200 on plans 2A, 2B, and 3. The mode deductible increase is $300. In scenario number 2. So let's just focus on that one. The $300 deductible scenario, then all deductibles would be going up $300. And then in the MODA package, office visit copay is up $5. And that would be for everybody on the plans 1 through 7 today. And then Garner is a choice. It's a choice incentive for members who want to get care through Garner. And Garner is basically, there's probably a couple different ways to think about it. One way to think about it is it's an available $700 reimbursement per individual or $1,400 reimbursement per family off your out-of-pocket costs. If for you don't mind searching through the Garner app. Everybody's plans are going up anyway. If you want to keep one of your providers and they're not through Garner, it's a choice. Depending on if it's an expensive procedure like a knee replacement that would be subject to the deductible, then you'll feel that benefit increase. If you're keeping your PCP, the copay difference from last year would be only $5, so a very small change that way. So it impacts different types of procedures differently. But the Garner, because we know that these providers that are in the top quartile, they're on average, they charge on average 24% less. So when we can have members with no sacrifice in quality, when we can have members go to them instead of providers that cost 24% more. It's a savings to the plan and a savings to the member as well. But there's really no penalty. And I know access has come up a couple times, and we wanted to talk about it with you, and Andrew went through all of the access slides this morning. So maybe I'll pass it off, Andrew, if you don't mind. You want to just summarize access?
Yeah, I'd like to. Hi, everyone. I'm Andrew. I'm Mercer Consulting, working on the PEP side, and so I participated this morning in CIAO, and we took a pretty close look at the access for OEB and PEP members across the state to this Garner incentive. And so essentially the access to those Garner top providers mirrors largely the access and known access issues that exist today across the state. So for example, we know there are access constraints in the southeast part of the state. And so that's also true on the Garner side. And so per Kirsten's comments earlier, members have choice with regards to how they use that incentive regarding what type of provider they want to use it with. So maybe they don't have a PCP that's a top provider that's, convenient driving distance to them. But perhaps they know that they're going to be seeing a gastroenterologist, and that is one of the top providers that's more conveniently located near them. So there's that to keep in mind. The other important point to keep in mind is that a lot of these top providers have virtual capabilities. And so in some instances where appropriate, if you can do a pre-appointment or a follow-up visit virtually, those are all eligible for the incentive.
So is the moral of the story that deductibles are going up regardless?
Yep. Minimum $300, if that can be something.
And that this is a way to potentially help mitigate some of those costs, out-of-pocket costs.
I want to say what you said differently, right, on this chart from an MBA guy, right? So the object is, with the plans as they currently sit, we're short $60 million. We need to generate $60 million in cash or savings either way, right? So all of these are just adding up how we're going to save 60 million. And the two that are here, which is MOTA benefit changes and Kaiser benefit changes, these are your increases in deductibles. So you can see in this option, this is how much we have to increase deductibles by. This option, this is the least amount of this, and it's because this is adding $8 million in savings by having Garner here.
And if we don't have
If we don't have it, it's here. Now we have 28 and $22 million in deductibles we have to raise, which is way higher, right? So we're using Garner as a savings because we're doing more efficient production. So that saves 8 million. Doing this stuff up here this is concessions from Kaiser and MOTA are saving us money.
Yeah.
But in the case of here it is, if we add fertility, this is in parentheses because it's costing us money, right? So we have to change that around. So we wouldn't be doing that here in this scenario to keep these two numbers down so that it stays at the 300-ish mark. But if we come out of this and go over here, these goes way up, means we're going to raise deductibles a lot more. Is that?
Yeah.
So this is a positive to get us to the savings. Is why it's an option on the table.
Yeah. Okay. Thank you.
So we're gonna save 8 million, or we are gonna pay?
That's the estimated, savings. Savings and payout is gonna be 8 million in savings is the actuarial estimate on how much we'll save if we implement Garner.
And how much is gonna cost us?
The cost comes through the claims process.
Yeah, let's talk about some financial transparency related to Garner. So $8 million savings is the net. That's the net claim savings. And again, claim savings comes because members now are seeing providers that have higher quality, lower cost practice patterns. So we have some savings on those claims. There is a Garner admin fee, and MOTA's been contracting that with them and making sure that that fee is competitive and does consider the joint purchasing power of OEB and PEB as well. And there's a guarantee if we don't achieve our savings target. We're finalizing those numbers. They're going to depend on what you as a board decide to do. But at a minimum, the full admin fee will be guaranteed if the savings figure isn't achieved, plus some of the savings will also be guaranteed as well. And then MOTA, the incentive fee is just billed through claims. as it is being paid to your members. So that's just a pass through. MODA's not getting anything from Garner. Garner's not getting anything except for the EPM admin fee. And then there's the savings guarantee on top of that.
But
Why ask?
But
Thanks for asking.
do you have an estimate how much to Garner, do you have an estimate how much money you're gonna make?
Yes, so our admin fee, again, that's 100% at risk, is $5 PEPM, so across the whole population. I believe it's roughly 2.7 million.
For 1 year?
Correct.
Is there another way for people to access the Garner benefit without the app? And I speak for people that don't have smartphones or people that aren't necessarily tech savvy that might be like, Sally, help me, right?
Sure.
You know, and they're not gonna, right? So
Yeah.
is there a dashboard or something, a phone number?
We have a dedicated phone number
Okay.
for OEBB members.
So there are
Yes.
multiple ways to access this, and it will still get them within that Garner. They'll get that reimbursement
Correct.
somehow.
Correct.
And Sally, MODA's plan also is to integrate Garner in all of the MODA member materials as well. So a member would log on to their MODA dashboard and see Garner.
Okay.
Their 360 app and see Garner. So there would be a point of entry through all of the known current MODA communication methods also.
Okay. There are a lot of members I do a lot of really one-on-one help with. So that just really have issues navigating the system. So I want to make sure I have all the information that I can to make sure that they're getting the best quality care.
Yeah.
Just to address that question, so
Yeah.
I think it's a really great question, and it's one that MODA thinks a lot about. And Kirsten's right, we will be integrating Garner into our MODA 360 app and dashboard. So members who already use that, they can continue just to go straight to MODA, and they don't have to think about where do I go. Members can also choose to go in through Garner. We like to think no wrong door at all to get to the right place. And then also this question came up during CL today too, so sorry everybody for repeating some of this again, but I think this is important. We also agree that we want to make it as easy for the member as possible. We don't want to have a member to have to sit and think, okay, where do I go? Who do I call? And we like to have the philosophy of a single front door and no wrong door to get in. And so we will also be working very closely with Garner and our Health Navigator team, because there will be more handoffs that need to happen between our Navigator team and Garner and our Navigator team. And we don't want to have the member to have to think about that or how to navigate that. That's part of the whole point of our MODA 360 program, to take a lot of that stress out of the members. So we will be working very closely with Garner to streamline that member experience as much as we possibly can.
Thank you.
Thanks, everyone. So the last aspect, certainly not the least important, just kind of the natural flow of how things progress today. We want to make sure we talk about the health equity work that was done on the Garner solution also. So I'm going to pass it back to Ian to summarize that conversation around health equity that we had at the CL committee this morning. And then we can, probably it's time for a break. And then we can take a break, come back, see where we're at with Garner, and move on if we're ready.
Thanks, Carson. Yeah, so, we applied the health equity framework on the Garner solution and took a look at it from a member experience access as well as provider congruence. There's some positive, but obviously we've also identified where and communicated to Garner that these also are expectations to improve on some of those parameters. With the member experience, that was critical. Things to our positive was the putting the choice in the hands of the members, but we realized that the education communication was key. We have just physical challenges plus communication and all the other aspects that have to be contemplated. Similarly, we also identified the need to have customer service be aligned with just the nature of our educators and their schedule. And I think there was a discussion that it is being negotiated and figured out how do we have a dedicated team. The hours are Pacific Standard Time, not East Coast time, and all those other factors that are just practical. So those are on the table, as well as language support. So Nick mentioned English and Spanish currently, but again, the diversity of our population requires additional coverage, and those are things that are being worked on and discussed. Access is key from a couple of parameters. Obviously, since it's based on our network, it's no worse than our current state, but that isn't ideal. So it's a combination of how do we make sure that there's information that creates that member decision about when is that quality worth the extra effort, travel or whatever. What are the thresholds for wait time that's appropriate? So obviously there's hard limits, but our clinicians able to be accessed when that member has that particular need. Concierge will be supportive of that and getting members in as appropriate, commensurate to their the priority of their clinical state. But these will be things that are sort of in progress work to optimize, but we sort of created some parameters for minimum expectation for PCP wait time as well as specialty. On the provider congruence, obviously it's very important to us. Right now it's limited core visibility around gender and a couple of languages, but we communicate that race, ethnicity is important, LGBTQ, TI plus experience and other preferences that members may have to make sure that's visible. Right now, it is going to have to be a conversation through the concierge to get that level of insights. Again, over time, if there's a vision that they want to also build their app to be more relevant to diverse population. The last thing that I'll touch upon is more on the clinical algorithm and making sure that they're doing what they can to risk adjust on the front end to make sure that different population needs are being factored in with regards to the quality score. But they also agree that, and they're going to work on things like testing for internal biases, right? So every physician has a different panel of population mix. We want to account for that, but then within those different segments of the population, are providers bringing in biases that we can identify and make sure we try to address and optimize. So I think there's a lot of positive things that are put on the roadmap in terms of expectations that OEB would have should this process and partnership go forward. Questions about health equity and that aspect?
Okay, nothing online.
So why don't we go ahead and take a 10-minute break? It's 2:40. Let's re-engage at 2:50.
I've never been to that.
Nobody does very one first.
All right, everybody. Let's get back into session. Although I don't quite know what our next piece is now. Is that what we're doing? Is that where we're at?
No, I have
No.
a proposed order for us. When
Okay.
we're already, yeah. But I feel like
All
we're missing a lot
right,
of.
we're back in session. Let's go ahead and roll along here.
We wait for Cheryl and Sally.
Oh, 1, 2, where'd everybody go? 1, 2, 3, 4. They went to Olive Garden? Oh, there.
Yeah, we're to Olive Garden, we'll be back.
Hope the microwave is working because it's cold. There's a big front moving in. We were just looking at it out the window on the other side, so it'll, the weather will change here momentarily.
I feel like it'd be appropriate if there was thunder and lightning on the drive.
Yeah, I'm aware. So we're at 5. Who's everybody else?
I don't know.
What'd you do with them? Are they stuck on the
I
internet?
got mine before them.
Oh.
Or
I
if
thought
we're
they
eating food. Oh, okay, yeah, let's just wait.
They're stuck on the International Space Station. They can't get home.
It's a nice drive over this morning. Saw 2 little babies, bighorn sheep,
Was that right?
frolicking in the.
Off of 84?
on the hill.
Off of 84?
Tells you it's spring, huh?
Yeah, they were cute. Woodward.
Emily's gonna go check.
Sally Cheryl. Okay. Why don't you propose your schedule while we're waiting, just because that's not really what you're thinking on how to proceed for the next session.
Yeah, so first, maybe we could take everybody's temperature on Garner and see if we have enough, burning up stuff. See if we have enough information to move on, at least talk about the benefit changes, the major medical benefit changes, and then there's 2 much smaller sets of material to get through, just a couple slides in total. There are a few clinical recommendations that have come out of CIAO that are not Garner, promoting the OHSU's Mold Mapper Skin Cancer Tracking app, menopause support through MODA with a slight premium increase, and then fertility benefits, which is not new information to you. So a couple small clinical things. And then we have some clinical programs, mostly dealing with cardiometabolic treatment options that we're paying for with RSR. You might remember some of those: Weight Watchers, Virta, and then Gabby, the new breast cancer screening tool. We've been paying for those out of RSR, and we've budgeted to do that again for next year. Just need your blessing on that. So that should be relatively straightforward. So the bulk of what's left are the medical benefit changes that go along with the options, and then a couple of clinical things, and then the endorsement on continuing some clinical things with RSR is what's left. And we propose going in that order.
Information on those apps, but as far as utilization and, are they worth the money to spend? Are they being used? Are they successfully being used?
Do you mean the OHSC Mold Mapper app?
Like the Gabby and those kinds of things. Like I'm all for it. I just was curious if we know.
Yeah, so if that's where you guys want to start, we're happy to start there.
And you can start wherever, sorry. Just do your thing. I will.
Yeah, maybe just in the interest of time, Sally, we should get through the big major medical ones. But we'll certainly answer your questions when we get to that slide. All right, so let's just refresh our memory on slide 13. Slide 13 lays out the 4 options. And of course, this is just Mercer brainstorming review based on what we know about you and what we've been able to uncover and work on with your carrier partners and Garner and staff over the last month in terms of different ways to achieve $60.2 million spending gap. In each one of these scenarios, so scenario 1, as Bill pointed out before break, is without the $8 million Garner funds. And of course, the Garner funds buy us some flexibility is the point with that, in addition to helping us with member out-of-pocket costs and high quality care. Scenarios 2, 3, and 4, they're just variations on a couple things. You'll notice the top section is all the same because we're never going to turn down a carrier concession or the admin rate hold, right? So those are in all of our scenarios. What's different are the benefit changes. In particular, do you prefer the lower office visit copay increase and the higher deductible increase or vice versa. So that's something that's different between those scenarios, and we'll show you here on the next slide. And then the MODA margin, that's just the delta to get to 60.2. So once everything else pencils out, how much is left over to get to 60.2? And then that's the reduction in MODA margin. And remember from before break, we talked about that's cushion in the MODA renewal calc. It doesn't flow to MODA if we don't spend it. It flows back to OEB because it's part of the minimum premium contract. It's there as cushion to help absorb unexpected increase in claims. So when we reduce our margin, we have less wiggle room for next year, is why we're being judicious with that.
Kristen, so just to reiterate, or to make sure I'm understanding you, the higher the margin, the less impact for next year's premium. Is that what you just said?
Yes, but to make sure we're on the same page. So the way we've laid this out, these are sources of savings.
Right.
So we'd be pulling from the margin balance this amount,
okay,
which leaves, we have to do a little bit of math, but it leaves about 6 million or 7 million minus this amount left in margin. So these were amounts that we were comfortable with for next year, given the state of the renewal increase and the pressure we're already having on benefit changes.
so we don't foresee then with a higher amount, are we looking at how are we going to figure this out next year because it's going to be even bigger?
Yeah, thanks for clarifying. It doesn't work the same way as a straight subsidy.
Okay.
Yeah, if claims trend exactly as we're projecting in the renewal increase, then the margin wouldn't be needed. Yeah, it's different than subsidy that way.
Thank you.
Yeah. All right. So let's look at slide 16 next, please. So the way these are laid out, we requested many benefit options from both Kaiser and MODA. Some of them just didn't pencil out financially. Some of them did. Those are the ones that are included. So there's 2 different benefit options for Kaiser. One you saw last month. The other one is a result of your feedback from last month, going back and partnering with Troy and Sapari and their team to see how else could we do that. And then similarly, we worked with MODA to come up with 3 different benefit choices. Really just dealing with different levels of deductible and office visit copay increase. So let's start with Kaiser Permanente option 1. This was in our first scenario without Garner. It has the biggest amount of savings. We've already heard feedback from you that the deductible increase on plan 1 of $600 coupled with the 10% coinsurance was too drastic. And so that prompted us to go back to the board with Kaiser and say, okay, if we limit the deductible increase to $400, where else do we need to make changes within the plan, and how can we do this equitably? So that's where we get to the Kaiser Permanente benefit change option 2. So in this option, the plan 1 would have a deductible of $400. And then in order for the deductible to actually provide any value, some services have to accrue to it. So outpatient surgery, inpatient, and emergency department services would be subject to coinsurance and deductible. And then the office visit copays. This is an area where we're trying to be equitable across all plans because deductible copays don't typically accrue to the deductible. So they're just another way to help take pressure off the deductible. So in this scenario with Kaiser, the office visit copays would go up by $5 for plans 1, 2A, and 2B. And then some services that are related that are also copays. So for example, the lab and x-ray diagnostic would increase as well, that one by $15, and the specialty scans copay by 30, 25, or 20, depending on the plan. The amounts are different because of where the benefits currently are today. The out-of-pocket maximum and deductible would increase by $200 for plans 2A, 2B, and 3. And then we mentioned before break, there is an enhancement embedded in this to help protect our families, which is that the family accumulator or deductibles and out-of-pockets for MODA and Kaiser in all these scenarios would be 2 times the individual. It's currently that way for plan 1, but we'd be making that change for plans 2A, 2B, 3, and all the MODA plans. All right, so for the MODA options, there are 3 different options And they're just combinations of deductible and office visit copay increases. And again, I just want to, in full transparency, we're calling out PCP and specialists, but copay benefits that are usually said to equal those, like mental health, also change by the same amount. So in MODA option 1, which is in scenarios 1 and 4, this is the $400 deductible increase and a $5 copay increase. The individual out-of-pocket maximum would increase $1,200. And then the deductible and out-of-pocket for the families would be improved to 2 times the individual. This is not in the recommended scenario, but it is in 2 of the options, option 1 and option 4. MODA benefit option 2, this is the benefit option that's in the recommended scenario. So it's Kaiser Permanente option 2 and MODA option 2 are both in the recommended scenario. The deductible increase is $300, and that's paired with an office visit copay increase of $5. And then for the out-of-pocket would increase by $900 for the individual, and then all the accumulators again would be 2 times the individual for family. There's a third variation for MODA, which is maintaining that $300 deductible level and having the copay increase by 10. This buys you a little bit extra benefit savings, which means we can leave a little bit extra margin for next year to help with the rate increase. That's the only reason that scenario is here. So if we want to go back to slide 13, we can see how those all come together. All right, so we talked about, so scenario 1 is the scenario that includes the Kaiser Permanente $600 deductible increase with 10% coinsurance, and MODA option 1, which is the $400 deductible increase and the $5 copay increase. And then in scenario 1, that's the no garner scenario. In all of these scenarios, we're adding the fertility benefit because the amount is really negligible compared to all of the other changes that we're making. So we're looking for ways to enhance things for our members wherever we can. A little bit of MODA margin helps to make up the difference here and get us to overall 3.4%. Scenario 2 is just the one that we thought would appeal to you the most and maybe was the most balanced and equitable across all of the different factors. Scenario 2 includes the Kaiser Permanente benefit change option 2, and that's the $400 deductible increase to plan 1 with 20% coinsurance and the $5 office visit increase with the $200 deductible increase on plans 2A, 2B, 3. And then the MODA option here as well is the $300 deductible increase and the $5 copay increase. In scenario 3, the only difference here is that this is the MODA $300 deductible increase plan with the $10 copay. And you'll see all it does here is it buys us a little bit extra benefit savings, so we need less to use less margin. Maybe set us up in a better position for next year. And in scenario 4, we just wanted to illustrate the flexibility that you have, understanding the trade-off with benefit changes. Probably don't have the appetite for this, but in this scenario, the garner savings is being used to add artificial reproductive technology. So that's our missing family building benefit at this moment for the MODA plans with a benefit improvement. So that they'd be covered both up to a $45,000 maximum here because that's what the garner savings could afford. So that's just illustrating an alternative way to approach this for you. And then I don't want to skip over this. There's a Kaiser Permanente benefit change because that renewal increase is also quite a bit above 3.4%. And that's a reduction in the benefit maximum from $4,000 to $3,000. Again, still is the highest benefit maximum of all the other plans, but it's a decrease. I want to make sure we call that. Michelle, do you have a question?
I just have a comment. I think when we talked about adding the fertility benefit for MODA, I feel like, and my recollection is that we kind of collectively agreed that this was the right thing to do from an equity standpoint. And so I want to invite members to consider scenario 4. And like if we had added the fertility benefit for MODA 5 years ago, and it was just something our members came to expect and understand as part of the healthcare they're entitled to, would this board right now be looking at that and considering taking it away? That is a decision that targets only women in their childbearing years. So it's basically saving money on the backs of a small amount of our members who need that healthcare. I think that scenario 4 is that's where I'm leaning right now because of that benefit, and I don't want to be. I don't feel like that is something. I don't feel like I can trade that away, because I do think adding the fertility benefit is an equity. Is a matter of equity. So consider, when you're voting, if we're voting today, would you vote to take that benefit away if members already had it? And if you would not, then I think voting for scenario 4 is the right thing to do.
Thanks, Michelle.
Other comments from board members? Any thoughts? In appreciation of Michelle's comments, though, but for the last 7 and 9/10 years, I've always been fighting for the least amount of out-of-pocket for our lower income members. I know we've had hard choices in the past, and this year is the most difficult. That's kind of where I've always had my tent. It's hard for me to leave that space. In the case of MODA option 2, the drug increasingly max $300, $100 deductible, and out-of-pocket max of $300. But I am fully sympathetic to Michelle's comment, putting me in a quandary. Should we go around? Should I point at you? All right. This is a difficult year, let's be honest, and by the looks of all you guys just staring at these numbers, I can tell there's no right answer here, no good answer here.
So I think I would ask first, does anybody have any other clarifying questions before we go around and discuss which is the stores?
Yeah, sorry we've discussed so much. If we went with scenario 4, where the MODA benefit changes are almost 11. No, sorry. 1 million more?
28,000. Or is that 28 million?
Okay.
28 million.
Yes, there we go.
28 million. Great.
What's increasing there?
So
Change?
your deductible is going to go from 300 to 400, and your out-of-pocket max goes from 900 to 1,200.
On the line.
In fact, scenario 4, Garner pays for, in effect, pays for the fertility treatment.
That's true, and then we recover that money by upping those deductibles and out-of-pocket max.
And we're saying, just one clarification, we're saying that the Garner savings would be used to fund the expansion of the fertility benefit. The member incentive is still available. So members who choose to engage with Garner and go to the top providers still have $700 per individual / $1,400 per family to be used
Yeah.
as reimbursement on their out-of-pocket
For
costs.
those that engage.
Yeah, that's separate from this savings that we're talking about here.
The Garner plan stays the same. It's just, we're increasing out-of-pocket match. Any other questions about the numbers and the proposed scenarios? Enrique, are you online now? In your car?
Yes, I have a question.
Yeah.
I also feel very passionate of scenario 4, but if we were previously we reviewed the graph that it's on the screen, but if we approve scenario 4 under this presentation, our out-of-pocket cost would be $100 per member. Is that correct?
Deductible's up 100, out-of-pocket max goes up 300.
Over scenario 2.
Sorry, that'll be for everybody, right?
Yes.
In MODA, everybody in MODA.
I'm sorry,
Did you say scenario 3?
It said 4.
I thought you said 4, yeah.
Oh, yeah, so I'm just reading it here, so yeah. So scenario 2, scenario 4, out-of-pocket, or deductible goes from 300 to 400, and out-of-pocket max goes from 900 to 1,200. In the scenarios being, person copay stay at $5. Right? That's the primary difference between 2 and 4 in the MODA side.
Yeah, an extra $100 deductible increase.
So basically, it's putting it on those that are using healthcare, right? And they can get some of it back if they engage with the new system.
So I understand Plan 4 and I understand what Michelle's saying, but to me, this goes back to our discussion on GLP-1 drugs as well. And we didn't do that one. If it were in the plan already, I would not agree to get rid of it. So I agree with, that logic, but it's not in there yet because we can't afford it. This plan hold on, scenario 4, I'm sorry, I'm getting the next one. Scenario 4, it's affordable, but I'm having real difficulty increasing by another $100 for everyone. It's really tough for me.
Yeah, that's kind of what I'm saying. That's where my tent has always been. Those who have been on the board for a while know that's where I live. Right.
Michelle, would you want to respond to that?
Yeah, I just want to say that this is different from the GLP-1 conversation because it's not like there's a narrow demographic group that's impacted by this, and it's women below the age of like 40 something, like I can't imagine this board making a decision that so narrowly affects one small group of our members with a specific demographic characteristic.
Well, it's kind of hard to respond to that, but I came into this looking for the greater good for the largest number of people. So I understand what you're saying, Michelle, and I'm torn on it. I'm just telling you where I stand, and I totally understand.
Sorry, I'm gonna put you on the spot. You're next.
I mean, I struggle in the constituents that I work with. It's a struggle for having enough money to pay for things. And so I tend to fall on how much can we save them or prevent them from paying more. And so that's kind of where I'm gonna focus. And I also am very cognizant of not wanting to push this concern to next year so that we have yet another great leap to make for those decision-making processes. So that's where I am.
I'll make a comment about that. finish. Dr. Laura?
Yes, it is an equity issue. I really concur with Michelle. What I'm seeing, like, I think it's 0.1%, right? In the total, no, no. Yeah, right, or
Yeah.
expenses. As Michelle mentioned, it is really a timing thing. But then also, in one hand and in the other hand, it's not $100 increase. Then you have the deductible is higher, and then I think it's a 500, 600, right? Up if you start to adding up, right?
If you have a family of 4.
Yeah, so it's more than 100. So I'm in a that hard place.
It's a hard one. This is a very difficult one, no question about it. So you're still struggling? Sally?
I mean, it's hard because I do, I see all. I see both sides right now.
Between 2 and 4.
Or do you have
I
a,
mean, adding the, yeah,
Adding the fertility.
and not adding fertility?
and not, it's, you know, stepping. I think it's a wonderful benefit, and I'm a woman myself, right? Like, and you know, if I was interested in having more children and could not, I want access to that. But you're right. We have so many, the greater good kind of thing, right? The larger impact, the most significant impact on the most amount of people is the increase. Right? And so, but it's difficult.
Agree. Let me, before I make a comment, I'll just.
I agree. When we have so many people that are so hard pressed to pay their bills, I mean, I went to the store the other day and eggs were $9 a dozen. I thought, oh my goodness, you know? Mm-hmm. So, I mean, healthcare is hard enough to get and hard enough to have to pay for. And I don't know that raising the rates on, 95% of our employees to cover the few that would benefit, I have a hard time seeing the benefit in that. Although it's a wonderful benefit, and I agree, I would love it if we had no other issues, but
it wasn't such a hard.
Yeah, it's tough. It's just tough.
So we heard from, on the phone, we have Michelle and Enrique, which we heard from, right?
Misty.
Oh, Misty, sorry, Misty.
Well, I'm unusually quiet because I'm so darn torn on this one. Can you guys hear me okay?
We hear you.
Yeah.
I'm just reminding you, you don't get paid for this, right?
What's that?
You don't get extra pay for doing this, right?
No, I just, women's healthcare and those options and availability are so important to me as someone that accessed it myself. And it feels, feels inequitable, but I also understand the majority of cost savings. So I'm really torn, you guys, and I'm never torn. I usually just know what I want to do. So I'm looking to you guys to help help direct me.
So I can add some extra 2 cents from me. That was everybody, right? Because we're missing 1, 2, 3. Yeah. Okay. So here's some extra thoughts from your fearful leader, right? But being that I can't run for re-election, I get to say something.
That's right. Go for it.
So part of the thing that I was focused on when I first got the numbers last month, and then been thinking about it, and I've shared it with some of the staff and things, is that we're going to look at some serious, and by we I mean you, are going to look at some serious hard numbers next year. Right, and there's things that are happening now that you all know are going to be really tough to deal with, such as tariffs and some of all the meds that come in from outside this country, various supplies, just even simple hospital supplies don't get made here, right? They're not going to get made here starting next year, right? There's going to be some serious price increases and costs going up. Next year is going to be probably, in my guesstimation, harder than this year. However, with that said, it allows us to tell our membership and our, what do we call districts, entities, hey, bad times. This is we're slow stepping this year, because next year you have a year to prepare for what's going to happen next year, which could include fertility benefits as well. You know, that we want to do that as an equity thing, and I know we want to do it now, right? But if we do that, then that gives all of our entities, our unions, and our members saying, hey, you've been told, you have a year, right? You know, prep your talks, prep your negotiations, prep your thinking, your mindset, that we're going to have a bigger struggle next year, and it's going to come around, and there's going to be no legislative miracle coming in the short session. Don't even count on that, right? This is going to happen, but by holding down what we have now in scenario 2, we're giving all these entities a year to really understand that things are going to be there. If we do it today, it's just like, you know, there it is, right? You didn't have that year. So as a school board member, you know, an entity is something who's trying to do budgets and keep education moving. That year can make a big difference in how we get our act together, right? Including yelling at our legislators, right? And everything else that we need to do. You know, had I known this was coming last year to this magnitude, because we kind of knew things was going to not be so great last year, but I would have been yelling a lot more than I am now. But I feel like that year of getting everybody a warning, and we need to make it a strong warning, and we need help with that from our staff and things, but that yeah, this isn't working. This the whole 3.4 concept that was invented, what, 17 years ago, right, is not happening, right, anymore in the new world that we live in. And prepare, right? So that's kind of where my mind is at, to limit the damage as best we can now to our education system, and give them a year to prepare, including getting these kind of extra benefits that we would really love to see. Not GLP-1, that's $2 billion, not $8 million.
Yeah, true. It was a bad analogy, I get it.
Yeah, but, you know, so that's where my head is at. I know I'm not really making your lives any easier by saying what I'm saying, but that's speaking from a school board and an education leader's point of view. You got to give me that time to get next year's budget ready for this, what's going to happen next year. Okay? So I'll reach out to my fellow school board member, understanding doing budgets and planning and doing layoffs. And we just had a layoff in my district. It sucks, right? Teachers are underpaid, but our custodians are way underpaid, right? And they're under the same plans, right? And you just have to sympathize with the person who's going to really be devastated by some of this. Could be as much as a kid's broken arm. You know, could put one of our librarians into bankruptcy with even what we're doing now if we do plan to meet, right? And I just struggle with that. That's what really eats at me, right? So anyhow, I'm done.
Maybe a few financial things, Bill. Hopefully Garner would help in that scenario. And that's where it really comes back to us to educate our members really well, because that is exactly the kind of person who's going to benefit most from Garner out-of-pocket cost reimbursement. But after the discussion today, as I mentioned before, there are not only 4 scenarios, right? Like, we have some flexibility in how we structure this. Potentially there's a scenario 5, which gets you what you are looking for. I'll have to talk it through with agree with you because it's kind of happening in real time, but I'm wondering in this scenario, because this was to illustrate using Garner for another purpose, the fertility benefit in this example is a richer benefit than what is available today. Today there's, I'm sure Erica can keep me honest, I think it's 15,000 pharmacy, 25,000 medical on the fertility benefit. In this scenario, this is an increase also in the annual benefit maximum, which is different than the Kaiser line, which is coverage of ART up to current maximums. If we were to do something similar on MODA, which is include coverage for ART without the benefit increase, so it's just an increase in the service covered up to current benefit maximums, it is less expensive. It would necessitate going with the MODA option, that's the $300 deductible with the $10 copay increase. So you maintain that $300 deductible, we'd have to get comfortable with the $10 copay increase. And then we'd still be short about $2 million. We have RSR funds available from MODA for $2 million. We've talked about the trade-offs with RSR. It's very tricky for the following year. You have to pay it back. So that's the trade-off. But that option preserves the $300 deductible increase with some level of ART. If we didn't want to tap into the subsidy at all, we would need to work with MODA on one additional nominal benefit change. So we'd have to look to some of the other services and say, okay, what if we added a $5 copay increase to this service? Some change to make up the $2 million difference if we didn't want to use RSR.
Erica? And maybe you can answer, but so MODA already covers fertility treatment to some degree. What is this covering that isn't already currently covering?
Yeah, so first thing for fertility coverage right now, it covers diagnostics, so diagnosing infertility, and then also IUI. There's no medical necessity review on that. So that means you don't have to meet a medical necessity, which means that opens the benefit up to potentially single people and then also same-sex couples as well. This one, Kirsten, I don't know what you priced in this scenario here. Did you price?
This is the 1.1% premium impact.
Okay, so what this is going to expand, it expands the benefit and then, so it increases it and then it's going to expand what's covered. So right now what we don't cover is ART or artificial reproductive technology, which is essentially IVF. And so that's what you're adding with this benefit right here, and you're increasing the coverage levels. So what Kirsten's saying is that you can look at that one and evaluate that, or you can add IVF within the existing benefit levels, which is less. So meaning under the current benefit levels, it might cover around, I don't know that it actually will cover around of IVF, but that's what Kirsten's saying.
That'd be hard. That's expensive.
Yeah, it'd be kind of pointless.
Yeah, well, I mean, help,
It's like
right? But that'd be your
several-
whole money spent. Right? I'm not gonna use that. And so again, that would be a step function because next year we would buy down using reserves. But again, warning all of our entities, hey, this $2 million, you're gonna pay it back next year plus the increases in healthcare, right? And again, you get a year's warning, to do this, but you're just making the problem harder. I'm good with that. I'm not saying I'm against it. I'm just saying that's how it works.
And I agree with you to a large extent because like being the benefits coordinator for the classified employee group, that's who I sit with is the custodians and the nutrition service and our ground staff and our EAs and the secretary. It's the lowest earning group. Yeah. And so for me, I feel like I have to choose all of them and not just a few of them.
Enrique, I see your hand up.
Yeah, well, based on what I'm hearing and the positions that we're in and the possible, most likely positions that we're going to be in next year financially, I guess I'm going to call the question for scenario 2. As much as I do not like the positions that we're in. That is my make motion.
Oh, did I hear you right? You made a motion for scenario 2 as presented?
Yes, I've presented.
I will second that.
Okay, so I have a motion from Enrique, a second from Sally on motion 2 as presented. I'll open the floor for discussions now on option 2, option scenario 2 on the chart on the screen right now. Open floor for discussion. And I'm going to include you guys as well, right, in this discussion. If you choose, you don't have to, right? Sorry, do I see, Enrique, is your hand still up or? Oh, Michelle, I see that's Michelle's hand. Michelle?
Can we at least see the scenario 5 that Kristen was talking about before we vote? I feel like I need to see that to know what all the options might be.
We'd have to edit live.
So the best way to think about that would be scenario. So yeah, I think I have to tell you about it because we'd have, so the MODA artificial reproductive technologies would be added to the family building benefit, covered at current benefit maximums, which I know a couple people have pulled up, so I'll let them say exactly what those are. So we'd have the covered service, not an expansion, which gets us on the road to equitable coverage. But then a couple things need to happen. That costs about $5 million, $5.5 million to do that. So it's less expensive than the
as opposed to the 8.
expanded benefit also, 7.9, but it's not 0. So the $5.5 million, we have a couple options for that. We could look for additional benefit changes with MODA to help cover that. We could subsidize the rates a little bit. I know you guys are all familiar with that. Maybe that's a back burner option. And so we'd be looking at some other benefit change to help pay for that.
I just say, with interest rates as they are right now, I mean, the loan stabilization fund's earning millions in interest earnings alone, just based on.
Understand, but we have to play the game that is money that doubles next year, right? Yeah. Yeah. That's the catch. And so what I'm describing is that the trend for next year is going to be bad. Like
maybe it's a small amount. I'm saying that.
Well,
that's it.
Yeah. Ali's saying there's another fund with money to do this.
Yeah. Understood. But it's 5.6 million, so that reduces the need to increase. If we pull a couple million out of that fund, and then we only do the $5 to $10 copay, is that what you were saying? $10 copay, right?
So Ali, are you saying that taking money out of the RSR is sustainable then?
Yeah, I mean, well, it depends on how much, but yeah.
We're talking 2 mil?
2 million, yeah.
So it's 2 million a year?
Yeah, that's a few months in interest, yeah.
So we could do the IVF in steps, right? You know, just add it to our coverage, jump the rate up from $5 to $10. Keep the same increase in out-of-pocket max, or deductible and out-of-pocket max, sorry. And then talk about it next year of increasing it to the richer benefit that we talked about now. Keeping in mind that we're discussing here option 2, an alternative. So I'll keep the logistics of the rules of order in my head. So just talk about that for a second. So still keep the discussion going. We're still discussing, right? Michelle, did you have a follow-up to what was just said?
I guess I would just say that I would vote no if there's a possibility of some kind of middle road.
So if we had a scenario 4.5, you would be voting no to this motion, and that's what you would do if you want to say for that we would vote down this motion and then re-motion.
Yeah.
But talk about it first so that we don't go in loops, right?
So then we're looking at the MODA benefit changes be less $2 million, so would it still be?
So we dropped to 5.6, used 2 million out of the art reserve, makes 3.6, which I'm hearing kind of, we make that up by increasing our copay book from $5 to $10, minus a couple dollars that'll balance everything out.
And then we need 2.3 million from one of our funds.
Well, that's what we just talked about, right?
Which is about 0.2% of money.
Yeah.
And
So that's doable. It'll have a minor effect next year, but you'll get 0.9% of an IVF treatment, right, covered, and that'll cover your max.
Yeah, and to clarify the benefit right now, it's $15,000 lifetime maximum for ovulation and, well, IUI. And then it's a $10,000 lifetime maximum for the medications. So that's correct, it would not cover a full IVF.
Yeah, but if we make that better next year, that lifetime maximums will go up, right? Or whatever it takes, right?
Depends on the financials, but we 100% could look at it again next year.
Yeah.
But I think to Michelle's concern.
But it has that possibility, is what I'm saying.
Yeah, it still is a financial help to the people who would otherwise pay out of pocket for those things.
Yeah, it's still,
That
I
is-
think we just need to acknowledge.
That is my concern, is that doesn't even cover a full cycle.
Yeah.
And we have to increase co-pays for everybody. It's just,
Is it worth doing? That's the question at hand, right?
yeah. So like primary care visit office co-pays for plan 1 instead of 20 would be 30.
Right, and that's
And with anybody other than your PCP would be 50 instead of 40. For urgent care would be 50. Mental health office visits, would that be 30 instead of 20 as well?
Right.
All of them would go up by 10.
Unless the Garner provider, in which case the
There's some
cashier will fully
reimbursement then,
reimburse.
right?
It
If
would be
you
$0.
And again, the other thing is to do what we've done in the past, which is say, okay, we're going to do this, but we're instructing staff who runs with Mercer to look at this for next year, right? That we want this as much as possible in the plan for next year. That's an easy, I would just say we're instructing staff to do that, right? If you wanted to say, okay, IVF, but we're going to do it next year, we would just instruct staff and they would be under command to do that.
At the same time, you said it's going to be worse next year than it is this year.
But you're giving your entities a year kind of planning potential, right?
Well, and listen, this
Yeah,
is
I
an
agree with you.
aside. This is an aside that there's not much planning. I mean, really,
Yeah.
seriously, you bargain over premiums, but premiums are capped at 3.4. What
Yeah, it's all out of pocket, yeah.
what can entities do to block that? They can't.
Yeah, it's more planning with the legislator to get a legislative miracle, right, or at least something. Right. The legislature's going to get hammered with this because PEB is going to have this exact same kind of discussion in 2 weeks, right? And they're covered under PEB.
If the 3.4 goes up, then you're still going to impact.
The caveat is I'm being a mayor who taxed my citizens, right? You want the smallest increase across the largest base. That's the mission, right? So that 3.4 is preventing us from doing that. So we have to hit the people with out of pocket. So if we can go to a formulatic 3.4, we're distributing that cost in a much smaller amount across a much larger base, which is what all taxation should be driving for. Right?
Yeah, Bill, after you talked about laying the plan out and broadcasting it for next year and not impacting our lowest paid employees by keeping the price lower this year, I see the logic in going with scenario 2, but also directing our providers that next year we want to include that component with the offerings for our crew.
Okay. There's kind of imply what you're saying, but I'm not sure, right? Yeah. Any other things before I call for a vote on the current motion on the table? And I am going to do a roll call vote if you don't mind. Right.
No, I just piggybacking that, like we're already increasing deductibles and then we went with a different scenario than plan 2, then we're jumping up all of the co-pays as well. And it's just a lot at once. And for me, I would prefer a slower crawl. It's
possible. And not because they don't want that benefit, but the most impactful, the least detrimental scenario two, in my opinion.
I echo that, and I can get on board with that as well, simply because I know that we're in budget right now.
That's why.
And I already know what I'm asking for next year, and 2 would work for us.
And that's what I told staff. I'm really hoping we pass anything this meeting because budget sessions are going on
Yes.
right now. So I want to
Yes.
pass something now so
Yes.
everybody just knows what
Yes.
it is.
Yeah.
Right. Okay, open floor again. Last call, before I call roll call. And I'm going to take this list from bottom up just because I'm at the top. Don't see any hands up. All right, Robert Young. Oh, sorry, I got to re-summarize my job.
I have a hand up.
Oh, sorry, I didn't see you.
I'm going to just make one final plea.
Sure.
We don't like increasing everyone's costs by a little bit to make sure our coverage is equitable feels like the right thing to do. It's what insurance is for. We all share the burden. We wouldn't choose any condition that is like a legitimate healthcare condition and decide not to cover it so that we could lower deductibles for all the rest of our members. So I just think, I think one way to frame it is we're trying to keep costs down for the most amounts of our members. But the way I see it is, lowering costs on the backs of young women who are in our members who have healthcare conditions that only affect women of a certain age group. So I'll be voting no.
Understood. And I wish if we could play with the 3.4, we would actually distribute this cost across the entire membership and not just those who need service, right? But I can't do that. Just checking hands. Okay, here we go. This is for all the models. What's that? Okay, yeah. Thanks. All right, so the motion on the table is to vote for the 2025-2026 rates to be based on scenario 2 as presented using KP option 2 and MODA option 2 as the method of getting the MODA plan changes and KP plan changes. Is that clear enough for everybody? Okay. All right. Good. Robert Young.
Aye.
Misty Wharton.
Yes.
Susan Miller is absent. Did Tony ever join? I just realized I'm not calling on him. Right. Bonnie Lucy. Dr. Andrea Lawyer.
Yes, we will know that next year we can go.
Understood. And we'll talk about that right away. Sally Durfee.
Yes.
Michelle DeBerry.
No.
Cheryl Berger.
Yes.
Enrique Farina. Rare.
Yes.
Chair votes for. Okay, so that takes the vote to 1, 2, 3, 4, 5, 6, 7, 8 to 1 with 2 absentees for whoever's keeping the notes. All right, for option 2, and now by consensus vote, we will say that we're just making an official notice by consensus to instruct staff to seriously look at the IVF benefit for the 2027-2028 plan year. All right, so if I could just get all in favor, say aye.
Aye.
Aye. Anybody against? Hearing none, that will just be for the record. So we have it on the notes. All right, so that means we're going to include you for the year. We'll obviously be looking for lots of numbers and engagement and how it's going. I want to point out something that I said this morning, and it wasn't really meaningful, but I just want to notify the board members because I won't be sitting here next year. Although this program is good, it requires a serious amount of things, and there's going to be a growth curve and an engagement curve. There's not going to be a step function starting tomorrow, right? So we're going to see a several-year plan where this has become really beneficial and members really engage more and more. Testimonial will be a big factor, as we go after the first year and getting more people to engage in our education system. We're going to rely on MODA and Providence to really do their due diligence in making this work, because it's also beneficial for them as well. But don't think this is just going to be a sudden, oh, we got 90% of our MODA membership ramming on this, right? It's not going to work like that. So just like with education, when we bring in new curriculum, pedagogy and things, it takes a couple years for everybody to ramp into it, right? That's how the game is played. All right. Go ahead.
For the contract with the governor, if you can take into consideration my feedback this morning.
Of course. Yeah, we wrote it all down. Bill, we have a couple more details to take care of this afternoon. Just want to make sure that didn't fall off your radar.
Oh.
Because he seemed like you were closing, so.
Well, not closing. I was going to go to the next item, but go ahead. What is your, sorry, go ahead, continue.
We need board approval on two things.
Oh, that's right.
So, yeah.
Sorry, my bad. Okay, continue.
No worries, they'll be quick, I think.
Yeah.
Rose, if we could please go to slide 34. So currently today, out of RSR, this is something we started a couple of years ago. We pay for some clinical programs with these funds. Weight Watchers, for example, Verda, Gabby, Mighty, and Pre-D through OMADA, weight management through OMADA, and Pre-D through MODA. So these are all clinical programs largely focused on cardiometabolic disorder, which we know is still a condition of concern for us collectively. We would, and Gabby was new 10-1, so we don't have good information on Gabby yet. We are recommending to the board to continue to fund these programs through RSR for the next year. We will fold the cardiometabolic programs into our vendor point solution evaluation process this next year, similar to you saw the results on the behavioral health this last renewal. So we'll fold all of the cardiometabolic stuff into that process this year and bring a deep dive on engagement and outcomes and more details around that next January, then roughly would be that time frame. So for now, just given this is still a condition of priority for our membership, we're asking you to approve continuing these programs and continuing to fund them with RSR, and the total $2.5 million for 25-26.
Sally.
Yeah, I had asked previously, but we've put on until now. Do we know the utilization of each of these programs? And then the Everybody Quits, Quit for Everybody, whatever that's called. You had talked about doing it per utilization, not per eligible member. Is that an option with any of these?
Onto that, yeah, so that came up in terms of tobacco cessation.
Mm-hmm.
So we are already doing that actually. So on Weight Watchers, John's been working super hard and with staff also negotiated 12% rate reduction on Weight Watchers this year.
Mm-hmm.
Part of our changes last renewal were to switch to per engagement pricing instead of a flat per eligible price. And then OMADA for Pre-D, Verda, Gabby, I don't remember where we landed, honestly. Per participant.
Yes.
Okay, yeah, so we're all participant. Thanks, Ian.
Yeah, we focused on that last year.
You know, we worked hard on that.
I haven't paid attention to a lot of them, but I have paid attention to Gabby, and nationally they're really doing some good work, and they're really addressing that 20 to 40-year-old women category quite strongly, and kind of impressive a little bit, in my opinion.
That's good to know.
Yeah, for a major women's health issue. Right.
Within OEBB, some positive benefits that are starting to get quantified. We're getting, of those that are participating, about 21% are identifying that they are at increased or higher risk. So these are individuals that would have not known that they need to do something different with regards to breast cancer screening and risk evaluation. And that's leading to about 82% of them doing a follow-up action as appropriately, like guideline-based, so it could be genetic testing or going off of the U.S. Preventive Service Task Force screening. So those are the benefits and the positives of that.
Thanks, Ian.
And that's also kind of a communications thing, just getting that message out to everybody is really, really key.
you want to vote on all the clinical stuff together, in which case we can wrap up. Rose, so if you don't mind, can you go to slide 31, please? The CIO committee looked at a menopause support this spring. Kaiser has integrated menopause support through their care delivery system. So this would be an addition for MODA. It would have a premium impact of 0.1%. Mercer felt like, given the climate and the other things that we had to forego this renewal season, that we would be better off adding this to family building benefits and really working on that hard for next year. So the recommendation would be to defer to the board, Mercer Scott. And then we talked about family building benefits already. So Rose, if you don't mind going to slide 29, please. Also, the CIO committee looked at skin cancer, which in terms of number of members impacted is actually OEBB's top cancer impacting members. OHSU has an app available already. It's free. It's called the Mole Mapper app. So this is really just an endorsement to all of our partners who work on communication efforts, that this would be worthwhile to message to our membership to make sure that they know that this is available. And at no cost. Yeah. Oh,
There's no cost, yeah.
perfect. Love it. We will, yeah, we need to bring more free staff.
Was that your key?
Yeah, I'm just scanning to make sure we're not missing anything else.
Yeah.
Critical. Yeah, but that's it, Bill.
Okay, so looking for a motion for the board to approve all point solutions that we currently have and paying out of RSR to continue those programs, and again, paying for them out of RSR, which we're good on. Not going for the menopause support, but putting staff into notice that we will do that next year along with the IVF view, and endorsing the skin cancer tracker app with our partners to promote the usage of that app for skin cancer
As
screening.
Bill said, I will make that motion.
Okay, I have a
I'll
motion.
second.
In the second. All right, comments? Misty, Enrique, Michelle, any comments? Nope. I don't know why, I can see everybody but Michelle. Why okay, never mind. Okay. No comments, so we'll do this by consensus vote. All in favor, say aye.
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 Anybody opposed? Hearing silence, that's a unanimous go on that. Is that good? Okay. All right, does that, am I not seeing anything else? Are we good?
We're all good. Just wanted to make sure we didn't have to come back. and go for a second.
I think that we're missing the concierge experience. Remember that I asked this morning, the concierge experience,
Okay,
if we
well
can
then-
test it.
Yeah, so the way,
Oh, he did point to that, but it
thanks
was.
for bringing that up. It was included
It's on the
in the
PDF.
option
In the app,
in scenario 2. If you don't mind, Rose, can you go back to slide 13, please? It was embedded as part of scenario 2. Yeah,
Yeah.
we'll show you where though, just to make sure everybody sees. Yeah, so here in scenario 2, the last item there is the Garner.
Garner.
Is that what you mean?
I wanna try the concierge experience.
Oh, the
wanna-
demo account.
You want
please,
to call,
yeah.
you want
I
to
wanna
be able to
go and
call.
I wanna talk and I wanna say, I think you say secret shopper. So I wanna, and then I'm gonna give you my feedback. Is that okay?
Great, absolutely. Yeah, we have demo accounts for all four.
Yeah, we were given demo accounts that he's gonna give us all on, and so you can play with it a little bit, right? Oh,
Welcome to the team, by the way.
Yeah, we're really excited at the opportunity to work with you all. Thank you.
And feedback to our staff.
Yeah.
You know, so make sure you give our staff the feedback, and they'll work with Garner during the contract negotiations.
So we'll start working on a communications plan and bring it to May and June, and, you know, how we can open up discussions about how we can best support you as board members and start getting that word out and be present for you.
Okay, we're gonna go a couple minutes long, because let's get a legislative update from Glenn.
Well, I don't know how I can follow that discussion, but.
Come on, this is legislative,
Yeah,
right?
it's legislation, and actually, just a level set right now for where the legislature is at. These next couple of weeks up to April 9th are probably one of the busiest times. The first chamber, mainly the policy committees themselves, are right now kind of furiously working to pass bills. And then the next step would be they either go over to the other chamber for vote. If they have a fiscal impact, they'll go to Ways and Means, which will of course take a more global look at those bills and seeing based on what the economic future for the state is, whether to send these bills back to the chambers for a final vote. That can last all the way up into June. I sent out a list of our current bills just for looking at our highest priority bill. Senate Bill 318 and Senate Bill 322, which are kind of identical bills, which would have provided coverage for substitute teachers who work at one or more of the districts. It would have required that the state reimburse the districts 90% of their premium costs, and it would really have put OEB in the position of managing this program, including setting rules for how you determine a eligible member, to how you determine the hours. It's very detailed. That had it has a really a large fiscal impact for us. Senate Bill 322 does have a work session coming up. It's already been shown that it would go to Ways and Means on that. Senate Bill 3517, since we've mentioned GLP-1s, that was a bill to require coverage for GLP-1s. That bill did not make the cut to get passed by one of the policy committees. Senate Bill 3212, which would really reduce our carriers' leverage in keeping down, really pharmacy costs by really kind of opening it up to more pharmacies and providing them kind of, I would say, almost a greater leverage over the PBMs. That has a large fiscal impact for us. It actually had actually they've just rescheduled it to the 8th.
I have a question on that one.
Sure.
It just says the MODA impact. Would that impact Kaiser as well?
No, because Kaiser doesn't use PBMs.
Okay. Thank you.
Senate Bill 211, which would have allowed physicians to get when they do physician administer medications from any source, even if they're higher costs. Right now, MODA has a program, a site of care program, to work with physicians to make sure that they use the most effective or cost-effective source for getting their medications. This would have prevented that, so we would have lost that savings from that program, and that bill died. Now, since we've been talking about IVF, there were two bills, House Bill 2959 and Senate Bill 535, which are basically identical bills, would have required that PEB and OEB, as well as other health insurers, cover all, fertility treatments, including IVF, without you couldn't add extra cost sharing under these bills. The second thing too is it would prevented us from right now, that we have a lifetime maximum on the fertility treatments for OEB and an annual maximum for PEB. Underneath these bills, we could not have these benefit maximums. So these do have some very large costs, especially for OEB, because it would require adding IVF. The House version died, but the Senate version has some hearings coming up. So, we'll kind of see on that. My speculation is, even if they pass it, well, it's not speculation, it would end up at Ways and Means Committee. And then lastly, House Bill 3092, which would have prevented the use of what's called copay maximizers, which are programs like MODA has a program where it helps people identify what are called copay assistance payments through the pharmacy companies, apply them at the point of sale, so the person doesn't have either has a reduced or no copay, as well as using part of this copay assistance to help reduce the overall costs on, that HEB and OEB and the help, MODA sees. This bill would prevent that. There's a sister bill for, PEB that would do the same thing. And by doing that, we couldn't use the program that the copay maximizers program that's currently used by MODA, and that savings would flip over to costs for us, increased costs. That is actually up right now, as pretty much as we speak on that. But again, these type of bills, with any price tags like these, they'll end up at Ways and Means. And then we have a number, we have overall probably about 50 priority 2, priority 3 bills that we're looking at, and then another 30 to 40 ones that we just keep watch over because they're relating, they could be amended down the line to affect us, basically. Are there any specific questions or any, I'm happy to answer on any legislation. You might have questions.
Anything you want us to go march on the Capitol on?
Feel free to contact Glenn or myself. Yeah, questions.
Hell no, we won't go.
Nothing
That
I
was
can.
last week.
Yeah.
You good? So you don't, if you need us to do anything, just always ask,
No,
right?
no, we're good for right now.
Thank you.
All right.
I have one closing question.
Yep.
Will it be passive enrollment this year?
Ooh, yeah, will it be?
Good question.
Do we know?
Yeah, we need to discuss that a little
Passive
bit. I
would be
think we've
lovely.
got a couple, oh yeah, it would be lovely, I agree, yeah.
I think it would be my favorite.
Yes.
I appreciate the input, yeah. We'll let you know soon.
All right, anything else for, just general topic, general comments?
Yep, we'll get together on the way up. You're driving home to Portland at Brick's Tavern. Please stop by if you have a minute. And I just want to thank everyone for their work today. Unbelievable job, and just thanks for coming down and logging in. And it's just really great to see that.
And I want to say for the room and some of you guys that I've been staring at for 6, 5, 8 years, really appreciated all my time here. This has been a great journey for me. Learned way more than I ever thought I wanted to know, but it's been fascinating being in this healthcare world outside of my normal world, and I really enjoyed my time, and it's been a pleasure. I'm staying till just that it's our last in-person meeting, right? So. All right, everybody, so we'll call it adjourned at 4:04. Thanks, everybody.
Are you running the board again?
Is it 1 or 2?
Sorry, just had to ask.